Welcome to this lecture on oncology and therapy. All right, so now we're going to talk about oncologic imaging. I'm going to start with the general ones like gallium and FDG, and then move on to specific types of cancer. All right, so gallium-67 oncology imaging is indicated for lymphoma, and that could be Hodgkin's or non-Hodgkin's. Hepatoma, some pulmonary disorders, some pulmonary cancers. Goes to a couple different infectious diseases. It's good for lung cancer, malignant melanoma, sarcoma, testicular tumors, multiple myeloma, head and neck cancer, and neuroblastomas. Recall the radiopharmaceutical for gallium. We have talked about this before when we did inflammation, so just make sure you guys know it. One thing I want to point out here, the half-life of gallium is long, which means we typically can't use a high dose, but we can use a higher dose than we do with indium. But the energy has 4 energies that are fairly high. So a lot of times you can scan it with a medium energy collimator. That used to be the way everybody did it, but the trend has really shifted to using a high energy collimator because then you have less septal penetration of the 296 and 381 keV. So it actually improves your spatial resolution. Remember, gallium is an analog of iron. And so it's transported in the blood by binding to the transferrin. And the reason or the way that it accumulates in cancer cells, not really sure. It's believed to bind to the transferrin receptors on the surface of certain types of cells. And those are overexpressed in those types of cancers that we're able to see. So it also binds to lactoferrin, and it binds to any protein that would bind to iron, and so localizes in certain kind of cancers that way. All right, so the procedure, we've already talked about the procedure, but I want to point out a patient should hydrate and void frequently during the first 24 hours, and then obtain images at 48 hours for oncology, and then 72 and 96 hours may be necessary as well. So you wait a little longer for oncology, and that's to give that gallium time to really concentrate in the tissue, clear from the bloodstream, and also clear from the bowel a little bit so you get nice, good pictures. So these are the normal, or this is an abnormal image actually. The normal findings over here are nasopharynx, lacrimal glands, blah, 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 blah. Abnormal is any activity that's listed outside of the normal. And this is actually a person that has lymphoma. If you can see the laser pointer here, all these areas in the chest and neck that where you see hot spots is where the lymphoma is. So now we'll talk about FDG. FDG is the main go-to for most types of cancer imaging. And it is used for malignancy, cardiac, and epilepsy. We don't talk too much about imaging brain tumors in this lecture, but I do want you guys to go back and review that. Remember, FDG goes to glucose-avid tumors. Not all types of cancer are glucose avid. There are a handful that are not. And but remember also that cancer cells are very tricky. They lose they get a lot of heterogeneity as the cancers progress. And what that means is they start to no longer look like a breast cancer cell or a prostate cancer cell. They look less and less like a breast cell or a prostate cell or a brain cell. And instead, they start to look just like a cancer cell, where they have this really shortened organelles because they don't really have a function anymore. The cytoplasm is smaller. Their nucleus is very enlarged, or they may have more than one nucleus. And it's just rapidly undergoing mitosis, and it just resembles a cancer cell that's only job is to multiply and grow. It no longer looks like prostate cancer, breast cancer, whatever. And so as it loses its as it gains some heterogeneity and gets sloppier and sloppier as it progresses, it gets more and more aggressive. Then it may take up sugar, but for the most part, some of those cancers just don't take up sugar until later on. A good example of that too, I want to say a glioblastoma, but patients never really live long enough for it to get to that point where it takes up sugar. They just don't. But one example of that would be prostate cancer, neuroendocrine tumors. I guess this is 3 examples, and fluorestradiol for breast cancer. As those cancers progress, they start to lose their function and structure of a normal cell and become just cancerous. And so at that point, if fluorestradiol, for example, is going to be having a lot of hormone receptors on the surface of its cell, and it's going to be hormone mediated. And so you might see it get taken up a lot on a fluorestradiol study. And then maybe you do an FDG and you don't see that. That's because those tumors are not metabolizing sugar. They're metabolizing those hormones, and they're using other things to grow and multiply. But as that breast cancer progresses, they start to lose some of the hormone receptors. They start to no longer look or function like a breast cell, and instead they start to look just like a cancer cell. When that happens and it switches to sugar, it is a sign of disease progression, and it is a sign that the cancer has gotten more aggressive. And so even though we say maybe not, you're not typically going to image like hormone mediated breast cancer or prostate cancer or whatever, it does kind of change to that over time as it progresses. And so FDG still plays a major role in imaging those patients, even though we now have like PSMA or fluorestradiol or dotatate. Even though we have those, it's still a good idea because eventually, as those patients are getting treated with Pluvicto or Lutathera, they start to lose their receptors for that other thing, the functional part of the cell, and instead maybe now they're just their scan maybe looked normal in FDG before, but now it looks terrible. And their fluorestradiol study looked terrible before, but now it looks kind of normal. It's because the cells changed as they progressed. So when we talk about FDG, keep that in mind that FDG is is not going away, and it is still very valuable and useful in patients that even are undergoing imaging with PSMA or dotatate or fluorestradiol. FDG is a sugar, so blood glucose levels need to be stabilized prior to the FDG injection, and it needs to be less than 150 to 200. That is going to change a lot. You ideally want it to be around 120 or, between 90 and 120. So where it says need to be between, that's typically the cutoff. It needs to be below 150 to 200. That's a typo there. We'll skip cardiac imaging because we already talked about that. Just know that and keep in mind that FDG is used for a lot of different things. Remember, it's cyclotron produced and the half-life is 110 minutes. Now, keep in mind that FDG is not just a regular normal sugar like we normally use. Our cells will take it up and recognize it the same as sugar. But once it gets inside the cell, the cell is like, hey, you're not what I thought you were. I can't use you. And so that's basically what happens. Typically, the glucose will enter the cell. It becomes organified, turned into glucose 6P, and then it is used in cellular metabolism. With FDG, it's taken into the cell. It's kind of organified that way. Kind of gets, well, I shouldn't say organified. It gets trapped in there. It gets converted to the F18 FDG 6P, just like glucose does. It's got that 6P on the end. But it can't actually be used for cellular metabolism. This is the reason that FDG does not increase your blood sugar. If you haven't heard this question already, you will get asked this question by a lot of patients, especially the ones who are diabetic. They will want to know if the FDG that you're giving them is going to increase their blood sugar. Diabetic patients and pre-diabetic patients are always worried about that, and they are going to want to know what you're giving them and if it's going to affect their blood sugar. The answer is no, it does not affect their blood sugar. And this right here is the reason why. It gets taken up into the cell, it gets converted, blah, 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 but then it gets stopped right here at the cell actually being able to use it. And so it kind of just gets trapped there and it gets. So FDG oncology is also used a number of different ways. Before therapy, it's used to look at tumor extent, find target lesions, get semi-quantitative and volumetric parameters. You want to see the SUV to see how aggressive the tumor is. And it's used for staging purposes, right? It makes a huge impact on the patient's treatment plan, what their FDG study looks like. And then ongoing treatment, new lesion response, seeing how well it compared to, or how well that it is metastasized, or how well it's responding to treatment. Those are the things that the answers that, oh my gosh, those are the questions that the ordering physician is trying to answer when he orders an FDG. They want to know if there's new lesions, if it's responding to therapy. They want to compare SUV numbers to see if it's less metabolically active than it was before. And then at the discontinuation of other treatments, like let's say they're through with their course of chemo and radiation and they no longer need any kind of treatment, FDG studies will still be done to monitor them, look at their metabolic response, see if a new baseline is needed, or that does create the new baseline, and then it's used later for comparison. These are the indications for oncologic PET imaging with PET-CT, solitary pulmonary nodules, and small cell lung cancer, head and neck, esophageal, recurrent breast, thyroid, melanoma, small cell lung cancer, mesothelioma, Hodgkin's and non-Hodgkin's, multiple myeloma, colorectal cancer, brain, cervical, ovarian, testicular, and pancreatic. One thing I want to point out that's missing there, other than multiple myeloma, you don't see a lot of blood cancer. So like leukemia is not on there. There's a lot of different types of leukemia. Those are not glucose avid, so it's really not good for that. This is the general rule for basic preparation. Avoid strenuous exercise, eat a high protein diet, restricted carbs, fast for 4 to 6 hours before injection, make sure they're well hydrated, ensure other medications have been taken, and you'll want to jot them down and make sure nothing conflicts. Breastfeeding mothers should pump and dump their milk for 1 day. Height, weight, and fasting blood sugar measurements are all recorded. The height, the weight, the sex, all of that goes into the acquisition or processing computer because it uses that as part of its normalization corrections. So a couple of very important things because they will affect the quality of the scan. No strenuous activity for 24 hours, fast for 4 to 6 hours, and then no breastfeeding, or if you are breastfeeding, pump and dump for a day. This is an overview of the diabetic population. Often they may have toast and juice at least 2 hours before. If it's less than 2 hours, then they may lead to increased muscle and soft tissue uptake. This will compromise the tumor uptake. So more of it will go to soft tissue, and then you may miss the tumors altogether. And then you typically want the blood glucose level to be below 150. This is an example showing you the effects of blood glucose on patients. With A, it's normal, less than 110. B is 110 to 159. Notice you see a lot more kind of soft tissue uptake around here, not as much detail in the organs, major organs. And remember, that's still pretty much acceptable. You want it to be less than 150 for diabetic patients. So still acceptable, but not great. And then for C, that's a high blood glucose. You're starting to see more soft tissue, less brain uptake. And then with D, the sugar is almost 200. You see that there really isn't a lot of uptake in the brain. You don't see the liver near as well. You don't see near as much activity in their soft tissue and organs as what you would expect. And you notice the FDG uptake, especially in the brain, was markedly reduced. And you also don't see a lot of difference in the liver or the lungs, but you do see less tumor activity. Contrast is often used with FDG PET scans, and it can be oral or IV. When it's IV contrast, it's typically a diagnostic CT. When it's just the oral contrast, it's typically everybody, the non-diagnostic CT for attenuation correction. But basically, that oral contrast will distend the bowel, and it can reduce the FDG uptake in the bowel so that physicians can more confidently exclude that. And so, if there is activity in the bowel, they can more confidently say that that's a spot of lymphoma or, tumor that's spread rather than just activity in the bowel. Omnipaque is the one that's most commonly used. Typical dose is about 20 milliliters. This is diluted in about 26 ounces of water or any sugar-free flavored water or lemonade. Patients will drink the contrast mix during the uptake period, and typically they'll get just a little bit. This is 50 milliliters, and the typical dose is about 20, so you give about a half a bottle, and then you dilute it in about 26 ounces of water or zero flavored sugar water or lemonade. What I see a lot of times is like a Crystal Light. Patients have that whole uptake period, so about 60 to 90 minutes to drink it. You wanted them to drink it all with enough time for it to actually get there. And then high density contrast can create artifacts on the images. So you use this low intensity and then you dilute it. The use of IV contrast is also fairly common with PET CT. This is typically done when it's diagnostic quality CT. There's really not a point in doing it when it's non-diagnostic because remember the KVP and MAS settings are low. So it's essentially like having a really low count rate image when it's used for attenuation correction. So you don't have good enough image quality to really risk giving the IV contrast, but also you don't really get the benefit from it because you have low quality images. So IV contrast should only be administered when diagnostic quality CT is used. Now, some states or facilities require CT certification for nuclear medicine technologists to give IV contrast. So It is important to know your state regulations, also advocate for yourself. Um, if diagnostic CT with IV contrast is used, then the CT protocol appropriate for the anatomy being imaged should also be used. And there's no statistically significant or clinically significant interference with standardized uptake values with contrast on PET. It will attenuate a little bit, but there's no significant interference from that. Um, some places will choose to do the PET before they do the diagnostic CT portion with IV contrast, just to make sure that that contrast doesn't interfere with anything. But there's a couple different protocol variations for that. Alprazolam is more commonly known as Xanax, and this is used in adults with head and neck cancer. It's given orally immediately after the FDG. This can reduce the skeletal muscle uptake that can impede lesion detection and confound the scan interpretation, especially, when you're doing head and neck. There's a lot of muscles, difficult muscle anatomy that's right around the spine and the neck. All right, so procedure for FDG, you want to identify the patient, change or remove metal, get their height and weight, patient history, make sure they're prepped, look at their medications, take their blood glucose, as long as that's okay, you'll start their IV and inject them with 5 to 15 millicuries of FDG, flush it really, really well. There is a question on whether or not to discontinue the IV at that point. Sometimes people will leave the IV in if the patient is diabetic or if their blood sugar was high or low to start, just in case they need to give them something else. Of course, if you're doing diagnostic CT with it and you're using IV contrast, then you could leave the IV in. It also depends on if the patient is having other tests later, if they're following their PET scan with a CT that has contrast or with an MRI that has contrast, then that's something to consider as well. Now, it's important to keep the patient warm. That will reduce the adipose tissue, the brown fat uptake, and things like that. So cover them in a warm blanket, keep them warm, have them rest for about 60 to 90 minutes, and then you'll have the patient go to the bathroom right before you put them on the camera. Position the patient. All of our procedures are supine, and so you'll position them, make sure they're comfortable, knee rest, all of that, arms up, arms down, whichever you're doing. I have seen if it's typically done with arms up, but they cannot lift one shoulder because it's really bad, then you can have them scanned with that one arm down. Just make a note of it. So the doctors know why, and that could produce a little bit of an artifact on the image. So it's important to document why and that they couldn't raise their arm. If they have any, or you want to give them breathing instructions, if there are any, typically that's just done when you're doing a CT with it. But you want to tell them, even if you don't have any specific breathing instructions for the PET scan, you want to make a point to tell the patient they can breathe normally. The PET scanner looks very, very similar to an MR and a CT scanner to a patient. Most patients cannot tell the difference, and most patients are used to having a CT where they have breath holds. And so they're expecting to have to hold their breath. And if you don't tell them they can breathe normally, then you might get additional breathing motion as they're holding their breath and then letting it out. Their breathing is going to be a little bit more labored after holding it for a while. And so that can create more breathing motion on the scan. So make sure you tell them they can breathe normally and try to relax. And then select the appropriate protocol on the scanner. You'll do the CT scout image. This is also called a topogram sometimes. And then you'll do the CT and then followed by the PET portion. PET portion is typically about 2 to 3 minutes per bed, but it depends on the anatomy being scanned and the radiopharmaceutical. It also depends a little bit on the scanner that you're using. Some of the scanners are digital now, and the digital ones have better spatial resolution and better sensitivity, so you can do even 1 minute bed positions. older scanners, you would want to do more time per bed position. And then, of course, if you're doing something like brain or the heart, it's only one bed position, you'll go for more time. And then afterwards, you'll reconstruct the images, you'll process the CT and the PET portions, as well as the fused images. And then you'll generate typically maximum intensity projection images, often called MIP images. And then it's typically displayed as the whole body. And then, of course, you have your slices of transaxial, coronal, and sagittal. However, if you're doing the heart, then you do the the reconstruction that way. But we're just talking about oncology today. So total body scan is done for certain anatomy. So whole body is done from orbital medial line. That's the imaginary line from the corner of their eye to the top of the ear. This is also known as skull to thigh. That will either cut off like most of the brain, if not the whole brain. You want to include a little bit of the bottom just so you know you're there, but um, it's it's going to go what we call skull to thigh or eyes to thighs. And most cancer is going to be found in that area. So for most cancers, you can do that and cut out the brain that is really glucose avid, and then also cut out the feet and the lower limbs that really aren't going to show anything. For some certain anatomies, you would need to do a total body, which is vertex of the head, the top of the head, all the way down to the toes. You want to make sure you're not clipping the head or the toes on that part. And then indications for doing the total body would be any kind of tumors that have a high probability of metastases in the head, skull, brain, or lower extremities. So melanoma can be found anywhere in the body. So that's one that you want to do all over. And then multiple myeloma also. Sarcomas like osteo, Ewing's, or chondrosarcomas can be anywhere in the bone. So you want to include the entire body for that. And then Merkel cell carcinoma also can be anywhere. So those are the big ones. There may be some other ones. Sometimes doctors may, um, patients may have something suspicious that they want to scan the whole body. And so if it's written on the order to do it that way, then you can. Keep in mind the patient is already injected. So as far as the PET portion goes, there's no additional radiation exposure to them for that. But for the CT portion, there is. And so we want to limit that and not do the whole body if we don't have to. This is the calculation for SUVs. You do need to know that calculation, but keep in mind you do the activity concentration divided by the injected body dose. And then it's in megabecquerels per milliliter and megabecquerels per gram. So that's how that is calculated. SUV calculations are done automatically by your software. You also need to know what they mean. Keep in mind those are done as baselines, and then they're watched to see how the tumors are responding to chemo, radiation, or whatever treatment they're getting. And if the SUV values stay the same or get lower, then we know that the tumors are responding, they're less metabolically active. But if the SUV values get higher, that's a sign that the cancer is more aggressive, and it's not responding, it's actually getting more aggressive and continuing to grow. All right, so now let's talk a little bit about thyroid cancer. Recall that thyroid stimulating hormone, and if they have elevated thyroid stimulating hormone, they're hypo. If it's decreased, then they're hypo. Remember, the thyroid stimulating hormone is what comes from the pituitary gland, and it's telling the thyroid what to do. There's a feedback loop there where messages are sent back to the pituitary gland telling the thyroid how well it's functioning. So if people are hypothyroid, they have an elevated TSH because that's their pituitary gland trying to tell the thyroid to produce more thyroid hormones to get back up to a normal level. When they have hyperthyroidism, that feedback loop is going back to the pituitary gland and telling the pituitary gland that the thyroid is over functioning. So the pituitary gland then decreases the TSH to try to understimulate the thyroid, so the thyroid will fall back into normal levels. So the TSH, a lot of times for students when they're learning, seems opposite of what it should be. But you got to think about what the thyroid stimulating hormone is and where it's coming from. And it's in the name, right? It's coming from the pituitary gland and it's stimulating the hormone's function. So if our thyroid is hypo, it's going to be higher because it's trying to stimulate the thyroid to work harder. So keep that in mind. Now, thyrogen, thyrotropin, these and recombinant thyroid stimulating hormones are used to avoid withdrawal from thyroid medications to facilitate iodine uptake. Patients have to withdraw from those thyroid meds. This can be unpleasant and can lead to hypothyroid symptoms for like 4 to 8 weeks. And there's a huge psychological and emotional component that comes with thyroid function. Withdrawing those medications can really upset people. So thyroid therapy can either be high dose or low dose. High dose is the one that's given for thyroid carcinoma. This is done also for ablation after it was surgically removed and ablation of local or distant metastases. It is given as a dose of 30 to over 200 millicuries. This is based on the uptake values and even the extent of metastases. I have seen where thyroid patients have thyroid cancer that has spread to their bones, and it's not uncommon for them to get over 200 millicuries. Doctors who determine that dose, it is based a lot on the uptake values of the thyroid uptake, but also the extent and the presence of thyroid metastases, whether it's in lymph node or bone or distant organs. If it's in bones or distant organs, then it's going to be a much higher dose because we really want to zap that out. The procedure for that, it is followed by the whole body imaging. This is considered that metastatic survey. And this can either be done after therapy without giving them another dose. So they get like, let's say they get 200 millicuries of I-131 for their therapy. They're going to follow up like 6 weeks later with a scan, and they don't need to get another dose of I-131 because it's still in them and it's in them enough to image. So keep that in mind. Now, sometimes we give I-123 instead. If there's not I-131 left in their body, we'll give them I-123 to follow up because that's better to image with. And iodine is iodine is iodine, so it's going to go to the same place. But they can do the whole body imaging before the therapy to assist with dose calculation and see the presence and extent of metastases. That's optional. But then the ablation dose is administered, and then they're always followed up with the whole body scan later. So, whole body scan beforehand is optional. Then they get the ablation, then they're followed up about a week later with the whole body scan. And that whole body scan does not require an additional dose. Sometimes people will get a metastatic survey scan where, let's say they had an ablation a year ago, and now all of a sudden they're getting symptoms or there's some kind of evidence that their thyroid cancer is back and has metastasized. Then they would get a metastatic survey where they get another whole body scan as a follow-up. That is typically done with I-123. It can be done with I-131, but remember, image quality is better with I-123, so most people do that with I-123 at this point. This is considered like the original theranostic agent because we can actually image and treat them with the same radiopharmaceutical, with the same I-131. Now, people will also get a low dose for thyroid therapy. The indication for that is primary hyperthyroidism. This is typically people with like Graves' disease or Plummer's disease. We don't really do this at Hashimoto's because remember, Hashimoto's is autoimmune. and patients will fluctuate between hyper and hypo until the thyroid kills itself, basically, or the autoimmune cells kill the thyroid. So Hashimoto's patients always end up becoming hypo over time. And so we don't treat them and just go straight to making them hypo. Although I have known some doctors who do that when someone is Hashimoto's and the Hashimoto's is out of control. They just remove the thyroid and put them on medication for the rest of their life so that patients don't have this flux of hyper, hypo, and all the complications that come with that. So primary hyperthyroidism, Graves' disease, these are the reasons to give a low dose therapy. The dose calculation for that, most common is to assess the size of the thyroid, the nodularity of the thyroid, and the thyroid uptake test. This is a fixed dose. Standard is 15 millicuries, and the dose range is typically from about 5 to 30. For the low dose thyroid, they usually will stay under 33. And the reason is because that's usually the trigger to make them be inpatients. And we can do this as an outpatient without risking the public dose. So typically 30 is enough to knock it back down to being normal functioning thyroid. Most of these patients do end up becoming hypothyroid later. For these patients, we have to discharge the thyroid medications for about a week. We do not give thyrogen injections for this. We do for the high dose therapies, but we don't for low dose. And they must not have received any iodinated contrast. That iodine in that contrast will saturate their thyroid gland, and then the therapy dose won't go there. So we want to make sure they're low iodine diet, no iodine, no contrast. And then iodinated contrast is like a CT with contrast, cardiac cath, or any IVP exams. Those all will have iodine in the contrast, so we want to avoid that. Now, if it is an inpatient for a high dose thyroid, there's quite a few things we need to do. Remember, the room has to be prepped. This goes for any high dose therapy where the patient is being done as an inpatient. And even in some of our therapies where they're there all day because they get prepped and then they get an infusion and then they get monitored, they're put in a room that's prepared this way also. All right, so on the door in this first image here, we see the caution radioactive materials sign, and then we see what's written here. You can't read it, but that's a list of instructions, and it basically has calculations on it to say, and patients are surveyed, right? So it says how much radiation is there if you're a meter from the patient. It says precautions of like how long nursing staff is allowed to stay in the room, restrictions on who can enter the room, and things like that. On the right image here, you see how the room is prepared with the chucks that are laid down on the counter, even on the handles of the sink, because if somebody has any kind of body fluids on their hands after they went to the bathroom or whatever and they go to wipe them off, then they're going to contaminate the handle. And so the handles are wiped absorbent side out, or wrapped absorbent side out. And then, of course, everywhere around the sink, the floor, there's an extra mat outside the shower where they're going to be dripping to absorb that. And then plastic all around the floor. So if there's any kind of body fluids or anything like that, that doesn't contaminate the floor. In their room, their waste should have a radioactive materials sign on it. Keep in mind, like anytime they blow their nose or they cough or just their utensils from their meal, usually they'll use plastic utensils that's got spit and stuff on it, napkins, plates, all that stuff is going to get contaminated. And so there should be a caution radioactive materials sign on the trash can, and they should have their own hot trash that they're instructed to put everything in. Tissues, all of that stuff needs to go in there. Nursing staff should be given radiation badges, and no pregnant personnel should be working around the I-131 therapy patients. They are emitting I-131, and that can affect the thyroid fetal development. So we want to reduce that exposure. Staff exposure time should be calculated and placed in the chart as well as on the door. And then anybody entering the room should wear the footy shoe covers and also have gloves on. And name and phone number of nuke med physician and the radiation safety officer are not only in the chart, but they should also be on the door. Let's say a patient falls and has an accident and there's blood everywhere, or there's urine contamination on the floor. That should be notified by the physician, the radiation safety officer, and nursing staff. Her housekeeping should not be cleaning that, right? They don't know how. So their bedside table gets covered. Phone, remote control, the chair that they're going to sit in gets covered, so it will absorb any sweat and that doesn't get absorbed into the chair. So all that stuff gets covered. And then this is shielding around their bed. Visitors should be standing behind that shielding and staying at least a meter away. Monitoring for the high dose therapies. Areas that are adjacent to the patient room are monitored and surveyed daily. This should not exceed 2 millirems per hour or 100 millirems per year. Those are the public doses. They're highlighted in yellow because I want you guys to remember your radiation safety. 2 millirems per hour in any given hour, or a total of 100 millirems per hour. Those are the public exposure doses, and those apply to anybody that's coming into the room with a high dose patient. If the dose exceeds the limit, then you calculate the amount of time that a nurse or visitor can stay in the room. So by doing that, you do the measured dose rate, and you divide that at 1 meter, and you divide that by 60 minutes, and then that equals the dose limit divided by X amount of minutes. So you plug the numbers in there, and that determines how long they're able to stay in there. The example I have here is if somebody reads 30 MR per hour. How long can a visitor stay at their bedside? We would do 30 MR per hour divided by 60 minutes. That gets rid of that hour, right? And then that equals 2 millirems per hour, because that's the limit, divided by X minutes. You cross multiply and divide, and you get basically 2 MR per hour times 60 minutes divided by 30 MR per hour. And that equals 4 minutes. So that's how long somebody should stay in the room with that patient if they're emitting 30 MR per hour. So discharging the patient, the NRC has 3 criteria for discharging a patient: when no individual member of the public is likely to receive more than 500 millirems from that patient, when the survey reading is less than 7 MR per hour at 1 meter, or when the administered activity is 33 millicuries or less. Any one of those criteria are met, then the patient can be discharged home. Remember, anytime a patient's going home after that, though, they have to be willing and able to follow the radiation safety guidelines and not expose the public. So this is where we have the whole body imaging that follows it. This is an oncologic procedure. It's also part of the overall theranostics of thyroid cancer. The rationale is that it's a very important part of thyroid cancer and follow-up. Typically, patients will have a thyroidectomy if they have thyroid cancer, and the whole body imaging is done to look for residual thyroid tissue and local or distant metastases. And then it's done before treatment and then followed up after. The pre-treatment one is, like I said, optional, but then it is done after treatment to make sure it actually went there and got all the thyroid tissue. So indications are, determine the ablation dose, look for metastases, and then confirm the presence and extent of any remnant thyroid tissue or metastases. They can't be pregnant or breastfeeding, and they can't have any recent nuclear medicine studies that would interfere with it. They need to be on a low iodine diet, no recumbent TSH injections or thyroid hormone replacement. TSH labs should be at least 30 MPO for 4 hours prior to administration. And then the dose range, if you're just imaging for I-131, it's 1 to 5 millicuries. And for I-123, it's 0.4 to 5 millicuries. It's usually given as a capsule. And then the dose range is 0.9 milligrams of recombinant TSH. That's administered intramuscularly on 2 consecutive days, 24 hours apart. The radioiodine is administered a minimum of 2 to 4 hours after the second injection, and then image the patient anterior and posteriorly whole body. Typically, you'll stop around the mid-femur because there typically isn't residual thyroid tissue or metastases beyond that. But I have seen a couple cases where there is, and I used to work with this really good nuclear medicine physician who specialized in endocrinology. And for some certain types of thyroid cancer or certain stages that they were found, he would have us go all the way down to the feet. And we did find some distant metastases that way. And so that's not regularly done, but your doctor may want it in certain cases, and that's okay. Follow the doctor's orders for that. There's a method to that because some types of thyroid cancer do have the ability to metastasize to soft tissue or have residual thyroid tissue in like a calf muscle or something. So we can use I-131 or I-123. Make sure you guys know that. We'll acquire planar images of the head and neck, 200,000 counts or about 15 minutes per view. And then you can do SPECT or SPECT CT with this as well. SPECT tends to be not great because you don't have a lot of counting statistics, especially with I-131. The image quality is never good if you SPECT, but if you do SPECT CT and it corrects for that and you can see the fused images, that is actually very, very helpful in figuring out if it's soft tissue versus lymph node and things like that. All right, so these are a couple normal pictures. It's normal to see activity around the sinuses in the mouth. They swallowed a pill, so it's normal to see stomach activity. Everybody's stomach is slightly different shape and size. These are 2 different patients, but you see that the stomach is a little bit more J-shaped in the one on the right and a little bit more circular on the one on the left. Perfectly normal. They just have different shaped stomachs. You may see a little bit of activity floating around the bowel as it's working its way down through the stomach. It typically gets absorbed in the stomach though, and so it should stop there. If you do see it, that doesn't necessarily mean, like in the one on the right, that there's metastases in the bowel. It doesn't really show up that way. That's just kind of working its way through with whatever water they drink. It is normal to see the bladder. It's excreted that way. You can see that the bladder is has that star effect in the left one. That's an I-131 image. And then that's it. That's about it. You may see a little bit of kidney activity, but that's normal. Anytime you see activity around the thyroid bed, in the chest, sometimes patients will have that substernal or sublingual thyroid tissue that's remnant. And remember, thyroid tissue is a bed, not a solid gland. So that's kind of normal for that to be expected. All right, so now let's talk about liver cancer. And this is specifically looking at hepatocellular carcinoma or metastatic disease to the liver. The therapy for this is Y90 microspheres. Indication is non-resectable liver carcinoma or liver metastases. The patient will receive a hepatic arterial catheterization with balloon to prevent shunting outside the liver. It's given as 2 to 4 millicuries. 99 mTEC MAA is injected into the hepatic artery for distribution. This is that HAPS procedure. And the MAA is used to make sure that there's not going to be too high of a dose that goes to the patient's lungs and just kind of like map that therapy. So it's a theranostic because we image with the MAA just to see where the therapy is going to go and then help determine the dosing. And then we administer the microspheres. So the dose is calculated based on information from biodistribution scan with the MAA and the estimated mass of the liver. Therapeutic dose is injected in the same manner as the dosimetric dose. So there are 2 types of microspheres. Thyrospheres and serospheres. Notice the thyrospheres are glass and they are slightly smaller. The serospheres are a biodegradable resin and they are about 35 micrometers. These operate in a twofold manner. For one, because they are microspheres, notice the size of them. They are big enough that they will occlude the blood supply to the tumor. Liver tumors are highly vascularized and they have a really, really complex blood supply where you have mixing of arterial and venous blood, and you'll have these very torturous, convoluted blood supplies because the cancer is um, having angiogenesis. It's capable of forming new blood vessels. It will steal blood supply from healthy liver tissue, but it will also create its own blood supplies, and it becomes very torturous. There's areas of blood pooling and clotting and all kinds of nastiness in that tumor. It's just messy, bloody tumor. And so the thyrospheres being a little bit larger, they have the ability to occlude the capillary beds. And so what they will do is choke off the blood supply to the tumor, and then the Y90 beta delivers that radiation dose. So it's kind of twofold. We choke off the blood supply, and then we obliterate it with beta, and that will kill the cancer cells. So that's the rationale. This is called selective internal radiation therapy, SIRT, and this is utilized to target primary hepatocellular cancer and hepatic metastases. This relies on the increased vascularity of the tumors in the liver and the principal blood supply of liver nodules in the hepatic artery. Now, when you're administering this, this is often done in a fluoroscopy suite. And sometimes radiation oncology wants to not include nuclear medicine. They want radiation therapist or the fluorotech to inject or to handle the microspheres, or they're going to be the ones injecting it because it goes into a shunt, but they want therapy, the radiation therapist or fluoroscopy tech or somebody to handle the dose. No, no, no. That is a big no-no. They are not allowed. It's not in their scope of practice. And we are the only ones that are trained to handle radiation. And you do not want any randos handling these microspheres because remember, these are like the super microscopic, weightless bouncy balls that will go all over the place. And the best way to clean them up is with that handheld vacuum or a shot vac. If there's a radiation spill, you do not want these people that don't know what they're doing with radiation handling them because it's an even worse spill to have to clean up. Go everywhere. So it's also called HAPS, liver shunt hepatic artery patency, or liver shunt patency study. Radiopharmaceutical for that is TEC-MAA, microaggregated albumin. Dose range is 5 millicuries. This is administered directly into the hepatic artery in interventional procedures in the department during hepatic angiogram. The patient will arrive from interventional radiology, most likely monitored by an RN following sedation. We'll place the patient supine in a camera, anterior and posterior, about 700,000 to 1 million counts. Field of view is the chest and the abdomen. We want to include the lungs and the liver. It will go from the apices of the lungs at the top of the field of view to include the entire liver at the bottom. Special care should be taken not to disrupt the injection site. Typically, this is in the femoral artery. Patient's not allowed to bend their affected leg, so you got to be really careful moving them and imaging them. It is optional to do SPECT or SPECT-CT. When the study is complete, you'll follow the facility protocol. Often it's required to return them to interventional radiology to complete the recovery process. So this is the microspheres dosimetry. Region of interest is drawn around both lungs and around the liver. The region of interest here was computer generated. That's why it looks like so weird. You can also do, some of them will just do the way they process a quant lung, where it's like a rectangle field of view divided into segments. Some of them will do over both lungs at the same time. So it kind of depends on the computer software as well. So remember, the Y90 microspheres dosimetry is the MAA scan that we're doing. And the dosimetry part of that is just the quantitative analysis and the processing that comes with it. These are processed very similar to a quantitative lung scan. The only difference is you're adding the region of interest of the liver, and you're comparing the uptake in the liver to the uptake in the lungs. So instead of comparing right and left lung or right and left kidney, it's a very similar analysis. The formula is even the same. It's just that you're comparing all of the lungs to all of the liver. And so you take the planar images, you have images of the lungs and you have images of the liver, right? And then you scale them, frame them, label them appropriately. And then for the quantitative analysis, most software protocols will have this already built into it. So you just click on the patient study and then you click on, the HAPS processing or dosimetry or whatever it's called for that one. You draw a region of interest around the entire liver and the entirety of both lungs, and then you calculate the lung shunting. And for that, you divide the lung counts by the lung plus the liver. So lung, this is the total right and left lung combined, divided by all of the counts, like liver and lung added together. And then you multiply that by 100, and that's your percent shunting. Most commonly, we will use the geometric mean values. And so in that way, it's processed very similar to like a gastric emptying, because the gastric emptying, if you recall, uses a geometric mean. But this is done if there's like anterior, posterior, or with right and left lung using anterior and posterior. And that way it's kind of averaging the counts from anterior and posterior positions, and then comparing that to the liver. So what do we use that percentage of shunting for? We use it to determine if and how much we would need to reduce the Y90 microspheres dose. So the methodology behind this, or the thinking behind this, is that, remember, the size of the microspheres are only about 20 to 40 micrometers. Remember, the capillary beds of your lungs are about 10 to 90 micrometers. So if you're injecting this radiopharmaceutical into their bloodstream, which you're doing that, but you're doing it via the hepatic artery, but you're injecting this into their bloodstream, and if some of it gets out of the liver and isn't like completely localized in the liver, then it goes to the lungs, and it's going to cause these microembolisms in the capillary beds of the lungs, the same way that MAA does. Only now, yttrium is a beta particle, or they're beta particles, right? Beta emitter. And so when you have a certain amount of radioactivity that's going to the lungs, it's not only causing microembolisms in the lungs by blocking these capillary beds, these are, especially the glass ones, they're not going to be broken down the way MAA is. MAA is like a albumin, it's like a protein. So your body will break it down eventually, and then it gets cleared out through your body that way. But these microspheres are meant to embolize. They're meant to stay there and choke off blood supply. They're not meant to be broken down. And so they will microembolize your lungs, and then they also deliver a beta therapy dose to your lungs. So they're doing that now to your healthy lung tissue, not the liver tissue that we actually want to kill. And so it's very, very important to make sure that when we inject that dose, well, the doctor does, but when that dose is injected, that it's not going to go to the lungs and cause a therapy or microembolisms or anything like that to the lungs. Remember, I told you that these hepatocellular carcinomas or liver metastases tumors are highly vascularized. They thrive off that blood supply. They're using that to grow. They're very, they just are hogging that blood. They really like this. They need their blood supply. But that blood supply becomes very complicated because the some of the components in the microenvironment of these tumors will cause a lot of new blood vessels to form. And remember, I told you that's complicated because sometimes then we have venous and arterial blood mixing together. Some of the blood vessels are intertwined or tied in knots around each other. It's a very messy, sloppy, torturous blood supply. And sometimes when that's happening, some of these blood vessels that are supplying blood supply to the tumor will mix in with regular venous blood that's going to other places in the body. So you're always going to have a little bit of activity that's seen in the lungs, but we're looking at how much because we don't want to do any harm to the lungs. So that calculation that I showed you on the last slide is done, and we look at the percentage of shunting. Each one of these drugs, they're slightly different. Remember, one is glass, one is resin, one's slightly bigger than the other. They're made by different companies. Each company did their own clinical trials and came up with their own guidelines. So that's why they're slightly different. For Serospheres, we use a lung shunting reduction factor. So if less than 10% of the activity went to the lungs, then we say, we don't need to reduce that therapy dose. We're good to go. That's not enough to cause significant damage to the patient's lungs. 10 to 15%, though, will do a 20% reduction of the dose. 15 to 20% of the MAA goes to the lungs, then we reduce the therapy dose by 40%. And if it's a greater than 20% shunting, you cannot do the therapy because that would deliver a lung dose that's too significant that will actually cause a lot of harm. We want to keep the lung dose per treatment to less than 25 gray. And so when it has more than 20% shunting, then the chances are that's going to be greater than 25 gray of accumulated radiation dose to the lungs. And so we do not want to do that. So that's a hard line that you do not give the Serospheres if you have greater than 20%. Really important that you get the regions of interest right so that that percent of shunting is accurate, based on how you draw your regions of interest and background. You can make it erroneously too high or too low. Both of those can be a bad thing for the patient. So we want to make sure that those are accurate. For the Serospheres, we don't do like a sliding scale reduction of dose like we do for Serospheres. For the Therospheres, we just look at the total lung dose limit per gray, and we say we want per treatment to be less than 30 gray of exposure to the lungs. And cumulatively, if they get this therapy more than once, we want it to be less than 50 gray radiation dose to the lungs. All right, so this is another example of the processing. You have the TEC and MAA, Serosphere static images. So these are the patient was given MAA. And then, of course, they're imaged. You see the lungs and you see the liver. Remember, they were injected through the port that was placed in there for the therapy. So they're not injected intravenously through their arm. That's why you don't see the lungs, you see the liver. We injected the MAA straight into the liver blood supply. So you should just see the liver. There's a little bit of thyroid up there. It's okay. We see a little bit of the lungs. So we know that some of this blood supply is not just supplying the liver. It's kind of complicated, and we have some spillover where it's supplying some blood supply to the lungs as well. And so the regions of interest were drawn around the liver and around the lungs. We look at lung anterior, lung posterior for left and right lung. This would be where we calculate the geometric mean because we took anterior and posterior images, and we're also looking at right and left lung. So Then we do liver anterior and posterior. We do a geometric mean for the lung and a geometric mean for the liver, and it comes up to 7.35% shunting. So as you saw on the previous slide, we're doing serospheres. That would be less than 10%. And so we do not need to reduce the dose of the therapy. These calculations, this table here is straight from a processing software. This is what it would look to you guys on your end. So that's not something that you're sitting down and calculating that math. But that's what it looks like. Now, with the dosimetry, you can also do SPECT and SPECT CT. This would be an example where this is fluoroscopy and image A here, where that is actually placed. This is the, I don't know if you can see my my pointer, so let me get my laser pointer. This is the outline of the patient's liver. Of course, this is their spine. What you're seeing here is where that port was placed under fluoroscopy to make sure that it's going to go to the blood supply for the liver. The reason that you see some of these colder looking shadows in here is because those are the tumors inside the liver. This would be somebody with hepatocellular carcinoma, and there are multiple nodules within the liver. So you see that there's like what you see there as looking like, I don't know the right word, blotchy. You see colder spots. Those are the tumors that are attenuating those x-rays. So image B is the dosimetry images for this patient. They did it like a whole body, and they drew regions of interest around both lungs together, the liver together, and then they did a body background that's kind of over the soft tissue. You want to make sure that that actually is over the patient's body, and it is. And then in image C, same patient, but now it is fused SPECT CT images. And so you see the MAA here in the colored areas over top of the liver. All right, so that's it for liver cancer. Now we're going to talk about bone cancer, which we did talk about some of the therapies there. You have the skeletal imaging, of course, with F18 or MDP. We already talked about those in first part of the module when we talked about the different, skeletal imaging. So F18 sodium fluoride, superior resolution compared to planar. We can detect metastases from several primary cancers. And remember that this is done with PET CT, and you have a lot better image quality. And then the second image is a bone scan using MDP or HDP. So you'll notice that you don't see near as much activity. Even though it still has a good target to non-target ratio, the images are a little noisier. See a little more body background and things like that. It's just not a sharp, crisp image. Just to compare the two, we did talk about this before. The typical dose is a lot less you give a lower dose, but it also stays in the body for less time. So you have a much lower effective dose for the sodium fluoride than you do for MDP. And injection to imaging time is quicker. So you get an answer quicker. It's better for patients that can't really lay around for as long or hang out for as long at the hospital or imaging center. The effective dose, though, is a little bit higher at the end of it, and that a lot has to do with giving PET CT instead, because you're using a smaller dose and it has a smaller effective half-life. And so most of this dose for the F18 comes from the actual CT portion. Although the sensitivity and specificity will change dependent on the pathology that's being imaged, overall across the board, the sodium fluoride has more sensitivity and specificity than the tech-based skeletal imaging agents. So That's something to keep in mind as well. You have higher spatial resolution, better sensitivity, and better specificity for the pathology you're looking for. So there you go. This is the slide that's showing the sensitivity and specificity. Notice that even with SPECT does improve it a lot, especially SPECT CT, but nothing really compares to the sodium fluoride SPECT CT that has 100% sensitivity and specificity. That means if there is disease in the bones, it will find it, and then it is very specific to what the problem is. So first we'll talk about bone therapies. Now, bone therapy indication is painful bone metastases with positive bone scans within 6 to 8 weeks. This is technically considered theranostic because they have to have a bone scan first, and then the bone scan determines the need for the therapy, but also is kind of, in some cases, it used to be used to determine the dose. For strontium and Xofigo, it's really not, but it's still used to determine like the extent of the bone mets and determine the need for it. So it is purely palliative. The bone therapies are never going to cure any bone cancer, but they are going to improve the quality of life and reduce the patient's pain. So they are never going to cure the disease, but they are going to help improve quality of life. These are meant to get that person through, typically these people are given months to live, and they've exhausted all treatment options. They know that they're going to die from their cancer or from the bone mets, and they're in severe pain from the bone metastases. These are typically people who have super scan or close to it on their bone scan. And so it's meant to improve their quality of life so they can get through like one more holiday season with their family, or take their spouse on their dream vacation, or, go see Europe one last time, or go on a cruise one last time. It's really meant for that, to just improve their pain so they can enjoy the time that they have left. And so there used to be another one called Samarium 153. That one's not produced anymore. It was taken off your boards, but the two that are still used are the strontium 89 chloride, also known as Metastron, and then radium 223 dichloride, also known as Xofigo. Strontium is beta. Strontium is a calcium analog, so it goes to your bones. If you look at the periodic table, go back to chemistry, they're in the same column, they behave the same. So it's going to go to your bones. And then the radium 223 will as well. It's very similar, related chemically. Radium will go to your bones. But remember, radium 223 is alpha. Strontium is purely or almost purely beta. Can't remember. It's on this next slide, so that's perfect. All right, so method of localization for these is chemoabsorption. The half-life is 50.5 days. There we go, pure beta emitter. I thought so. Max energy is 1.43, so it really does have a pretty high energy. It expires about 28 days after it's calibrated. Critical organ is, of course, the bone surface. It's really avid to the bones. It's that analog of calcium, so it does a really good job of going to the bones and not normal tissue. Think about a bone scan where you have a really high target to non-target ratio, meaning like our bone scanning agents will go to the bones but not the soft tissue. You don't see a lot of other anatomy on there. And so strontium is the same way. It's going to go to the bones but not really go to any other normal tissues. You'll see kidneys and bladder, of course, because it's excreted that way, but the radiation exposure is primarily to the bones. The dose is weight-based, 40 to 60 microcuries per kilogram with a max of 4 millicuries. There's some patient prep for it. With most of these, all of these therapies, you need to make sure that the patient is healthy enough to receive the therapy. So, of course, there's like recent bone scan, no myelosuppressive chemo, no radiotherapy. These are people that have exhausted all those therapy options, so they couldn't have had those therapies for a while. But the baseline CBC, that's the complete blood count that's done, that's just a basic blood test. But we're looking at platelets, leukocytes, and granulocyte levels because any of our therapies are really hard on blood cells and bone marrow. Go back to what you know about radiation biology. Those cells are stem cells that develop into blood cells, the cells in the bone marrow that become mature blood cells later. And all of those blood cells are very radiosensitive, and we're injecting it into their bloodstream. So it is going to kill some of their white blood cells and some of their platelets. We want to make sure that before we give any therapy, that those blood levels are adequate enough that they can kind of withstand the blow of a beta or an alpha therapy. So we need to make sure they're healthy enough to even get that therapy. Sometimes people have given them platelets, or people have, gone on special diets or whatever to try to boost their blood levels so that they can receive a therapy. And, those myelosuppressive chemotherapies, if you come right after and hit them with the bone therapy, that can kill the patient in itself. So we need to check that before we give them the therapy. Therapy is repeated at 12-week intervals as long as the blood counts are acceptable for that. So blood levels are checked the whole time before and during the therapies to make sure that they're okay. That would be the first sign of like a radiation sickness. You're going to see that their platelet levels and stuff go down, and we don't want to make the patient sicker than they already are, or for them to get complications of the therapy. So that's really important for all of our therapies. Just keep that in mind. All right, so now Xofigo. The indication for Xofigo is castrate-resistant prostate cancer with symptomatic bone metastases and no known visceral mets. That's a very specific thing. These patients had to have had prostate cancer. They were castrated, and there's no other metastases other than to the bones. And these patients will die from their bone mets. And their bone mets have to be very painful, right? They have to be symptomatic. So this is considered not just palliative, it does increase the survival rate. And this can be confusing because it is palliative, but it does increase their survival rate and increases their length of life. But nobody's gonna, I can't say nobody, most people do not just get cured of bone cancer from their Xofigo. Part of the problem with the radium-223 is being an alpha emitter and the first one that was FDA approved. It's considered a last option. All other things have been exhausted. These patients, their original prostate cancer is gone because their prostate was removed, but it spread to their bones. It's not spread anywhere else, but they're going to die a very slow, painful death from bone metastases, and it's too far advanced for chemo or radiation to be able to effectively treat them. Now, there are people who have improved with alpha. Alpha is going to kill cancer cells. This radium-223 is going to kill cells because it is alpha. It's going to go to their bones, deposit a really high radiation dose locally to those bones. It's very targeted, and so it will kill some of the cancer cells. This increases their survival rate. They live longer. Not only do they get some relief from the pain, um, but they will live a little bit longer. There have been some cases where the bone mets wasn't as advanced, and the patient got the Xofigo earlier on in their treatment, and for some of them, it almost completely cured their bone cancer. Didn't cure it, but it knocked it down like way, way, way a lot, and so they had a lot less lesions. But this is not the first line of treatment for anybody because of the possible long-term effects of getting an alpha therapy. So it's really given older patients who are not going to live, and just to help relieve their pain and help them live a little bit longer and live pain-free. But There have been some very rare occasional case studies around the world where it did cure, not really cure, but almost cure their cancer. It knocked it way down to where they only had a couple lesions there. And I don't know of any cases where people were actually cured and cancer free after their radium. So it's marketed that way as like it does increase their survival rate. And it has some curative properties to it, but it is still used in a palliative way. So keep that in mind. Radiopharmaceutical is radium-223. Again, this is chemoabsorption because it's a calcium analog. Half-life for this one is 11 days. It does have a low-level gamma that's emitted with it, and this allows it to be measured in a standard dose calibrator. It's stored at room temperature, and then the critical organ is the osteogenic cells in the bones. Now, Xofigo dose is 1.49 microcuries per kilogram. I know that's a super small dose. It's because it's small but mighty. It's given at 4-week intervals for a total of 6 injections. It's really important when patients start the Xofigo therapy that they're able to get all 6 injections and they're able to get them in a timely manner. Some patients start and they can only get Xofigo once in their life and then they're done. So if patients are, you know, after their 4th treatment, they decide to take their wife to Europe or their wife on a cruise and they can't be back in time for their next injection, then they're done. They're out of their treatment options. They cannot get the last 2 injections and they can never get Xofigo again. They can't just like start over. That's really important for patients to understand and be able to commit to those monthly injections for the next 6 months. And then emissions 95% alpha has a really high linear energy transfer. It leads to double strand DNA breaks. And so that 1% gamma does allow it to be measured in a dose calibrator. That 3% beta is also beneficial because that allows it to extend a little bit further out. Remember, alpha is not going to travel very far. Beta is going to have a wider treatment range. So it does allow to kind of reach out more towards the tumor edges with that beta. So, of course, the blood work, they have to have their platelets, their absolute neutrophil count, hemoglobin, all of that stuff needs to be measured and be acceptable. It is done periodically between injections, but if the patient's counts do not recover in 6 to 8 weeks, then the Xofigo therapy should be discontinued. So you can wait a little bit and make sure their blood recovers a little bit, but and otherwise it's discontinued. I have known of some oncologists who will give patients platelets and stuff to help boost their blood, put them on special diets to help boost their blood up before and during the Xofigo to try to make sure that their platelets don't fall below that or their hemoglobin fall below that line where they can't get the therapy anymore. A lot reliant on patient history also. All right, so now we're going to talk about neuroendocrine tumors. There are a lot of different ways to image the neuroendocrine tumors. You can image them with indium-111 pentetrotide, that is Octreoscan. You can image them with I-123 or I-131 MIBG. That is better for some types of neuroendocrine tumors like pheochromocytoma, which is in the adrenal glands. But it's not as great for others. It's also great for neuroblastoma. So I-123 MIBG has fairly good image quality and is used in pediatric patients who are suspected of pheochromocytoma or neuroblastoma. And then for the PET agents, we have copper-64 dotatate or gallium-68 dotatate, gallium-68 dotatalk, or even gallium-68 dotanoc. A lot of dotas. And then for the therapy, we have lutetium-177 dotatate. We also have I-131 MIBG with a brand name of Acedra. This was removed from the market in 2023. Most of the reason that this one was removed from the market is because it required injection of 500 millicuries of I-131 MIBG. That's a half a curie. That's a really, really high amount of radiation. And it's it's iodine-based tagging agent. So you did have a really high risk of the patient's thyroid because of the really high amount of radiation you are giving and the risk that that poses to the public. These patients need to be hospitalized. There's a lot of stuff to do with it, a lot of extra paperwork, a lot of extra planning. Nursing staffs had to be trained. These patients really needed to be kept. And the regulatory stuff that comes along with that just got too much. The NRC was going to change and make it so you had to hospitalize the patient. You couldn't release them to be home. Or one thing that patients would do in this case is they'd go to a hotel room for a week. They would order room service and they would not have like housekeeping. This is a problem because they're sweating in their sheets and their sheets become radioactive and the housekeeping staff doesn't know that. But you could, or they would release them home and their family would go stay in a hotel for a week or so. But it just was, the NRC was making rules that these patients needed to be hospitalized where it was a more controlled and safe environment for the public. And the red tape just became way too much for what it was worth. And so Azedra was pulled from the market in 2023 and is no longer made. We still have I-131 MIBG. We just don't have that as a theranostic agent for the MIBGs anymore. So now all we have is that Lutathera for patients who have pheochromocytomas. For neuroblastomas, there's clinical trials seeing if Lutathera, the lutetium dotatate, would be good for that one, but it's not approved for that use yet. All right, so we'll talk about indium first. The rationale for that is that it is a neuroendocrine imaging agent of somatostatin receptors. It's an effective way to evaluate a number of cancers preoperatively and for staging or restaging. This radioactive analog of somatostatin binds to the receptors and concentrates in the neuroendocrine tumors and other tumors with somatostatin receptors. So the rationale for that is that these tumors overexpress somatostatin receptors. And so by using an analog of that and tagging it, it will go to the sites of neuroendocrine cancer. So remember, somatostatin is basically the hall monitor of hormones. It goes around checking things and seeing if something is over secreting its hormones. And then if it is, it tries to block it so that it kind of brings it back down into its normal function. Neuroendocrine tumors are functional tumors. So their whole thing is that they're over producing hormones. And so as your body's natural response to that, more somatostatin is sent to them. And so they develop more somatostatin receptors on the surface of them because your body is trying to control itself, right? And get you back into homeostasis. So knowing that there are more somatostatin receptors on those cells, we take advantage of that, use an analog of somatostatin, bind it to the radioactivity, and then it can be used for imaging or for treatment. So that's the whole rationale of all the neuroendocrine imaging and tumor all the therapies. So Octreoscan is the one that we had the longest. This is kind of like the OG of neuroendocrine imaging. And it was really great drug for a long time. It's very rarely used now that we have the PET agents out on the market. However, there are still a lot of places in our country where you can't get the copper or gallium dotates, and maybe they don't have PET scanning available and they only have SPECT because, you know, the price and the logistics of it, they just don't have a PET scanner. And so in that case, some of these really rural areas, maybe they have a lower patient volume and it just isn't worth the investment of PET, or the amount of extra cost that it takes. Some of these Western states that are more rural, there's not a nuclear pharmacy close by. The PET doses come by plane, and they the pharmacies charge that to the customer when things are being delivered by plane, and so it becomes difficult to do that, to get those. And in those cases, Octreoscan is still the way to go. It's a very good drug. As you can see, the image quality just isn't as good just because it's indium and you're using a gamma chroma. You don't have all the benefits that you have with PET. So Octreoscan is used for all of the things that are neuroendocrine: pituitary adenomas, pancreatic islet cells, pheochromocytomas, which are in the adrenal glands, gastrinomas, guess where those are? They're in your stomach. Gastrinomas, small cell lung carcinomas, and carcinoid are the most common. Also look at paraganglioma, which is the adrenal gland tumors outside of the adrenal glands. That's where you have pheochromocytomas that are found outside of the adrenals. And neuroblastomas, which can be found anywhere, but usually in the brain, and they're usually in children. Carcinoid tumors are really, really nasty. Carcinoid is where you've had neuroendocrine tumors growing for a small period of time, and then all of a sudden they get super aggressive and people can go into carcinoid syndrome, which is there's not much hope for those people. Um, so the Octreoscan is used for identification, staging, and restaging of any neuroendocrine tumors, evaluation of the somatostatin receptor status, and assessment for therapy effectiveness. And then it's an alternative to MIBG in patients with pheochromocytoma that cannot withhold the high blood pressure or the antidepressant medications. Remember, MIBG has a whole laundry list of drugs you can't be on with it. And one of the problems with people with pheochromocytoma is that they can get really high blood pressure. People with neuroendocrine tumors also sometimes get anxiety and depression. And sometimes those patients cannot go off their medication in order to get the MIBG study. So that's where Octreoscan would be a better option for those patients. All right, so there was one thing I was going to say and I forgot. I don't remember what it was. If I remember, I'll let you know. I remember what it is. So when we talked about PET and we talked about the dotates, dotatox, all of those, recall that we talked about the importance of still doing FDG studies, and we talked about tumor heterogeneity. That happens with a lot of different tumors, and it makes treatment of cancer really complex. And basically, for neuroendocrine tumors, what we have is basic neuroendocrine tumors have somatostatin receptors overexpressed on the surface of the cell. However, as the disease progresses, the cancer becomes more aggressive, those cells they're undergoing rapid mitosis, and they start no longer looking like a neuroendocrine cell, which has somatostatin receptors on the outside of it. And instead, they just start looking like cancer cells. They can become more and more undifferentiated over time. They start looking more and more like a cancer cell. And so those cells don't have somatostatin receptors on them anymore. They're no longer neuroendocrine cells. They're not functioning like neuroendocrine cells. They're not producing hormones. And they don't need somatostatin receptors because they're not going to take somatostatin. And so all they're doing is undergoing rapid mitosis and manipulating the environment around them so that they can grow. So those cells are not going to take up octreotide or MIBG or any of the dotates anymore. They're going to take up sugar because now they're just your basic generic cancer cell that's entire purpose is just to undergo mitosis. And so people who have been having therapy for a while and maybe their cancer is progressing or their symptoms are getting worse, then they can undergo the Octria scan or any of these dotates. And in that case, we're evaluating the somatostatin receptor status, because you can give them octreotide, which is a non-radioactive somatostatin receptor or somatostatin analog that basically does the same thing as somatostatin, where it blocks all these receptor sites and it blocks the tumors from overproducing hormones, and it controls your symptoms that way. And so people will be on these long-acting somatostatin drugs, like octreotide, and then they work for a while, but maybe their symptoms start getting worse or they start getting sicker. This would be a good time to repeat the Octria scan or any of the dotatate studies, because at that point you're looking to see if maybe the tumor has progressed. We know the tumors are still there, but they're no longer taking up our somatostatin analog. That's a bad sign for the patient. That means they have more tumor heterogeneity and that their cancer is more advanced, and it's more likely that it would show up on an FDG scan, which is not good at all. All right, so the procedure for that, just review the procedure. They get 6 millicuries, and then you wait. Images are done at 4 and 24 hours. SPECT and SPECT CT are great for that. And then you also will do whole body. Laxatives should be considered if the bowel uptake is interfering, especially with some of those GI neuroendocrine tumors. Problem with that, couple problems. One is if you're looking for neuroendocrine tumors in the gut and they have bowel uptake and you give them laxatives, you could cause like a harsh laxative will cause an inflammatory response, and that can interfere with the images. Not so much with Actria scan or the dotates, but it can. And then you also, the bigger issue here is that those people already have problems with diarrhea. And it's not just normal diarrhea when people have neuroendocrine tumors. This is like they can't leave their house, they can't get too far from a toilet. It really interferes with their normal daily life. Some of them have to wear like adult diapers and things like that. And it's not any diarrhea that they can control. It's not diarrhea like they would say, oh, I gotta go to the bathroom, excuse me. It just comes out sometimes, especially as it progresses or the extent of their neuroendocrine tumors is really bad, especially with like the gastrinomas and um, some of those that are just the GI ones. And so if you're giving one of those people a laxative, that's really cruel. They don't need it. So some of those people just can't have it. It would be contraindicated in patients with diarrhea. Insuloma patients should have IV glucose available due to a possibility of becoming hypoglycemic. Insuloma patients, this is overproduction of insulin. And so these are a type of neuroendocrine tumor that's in the pancreas. It's a couple different neuroendocrine tumors that can happen in the pancreas. Of course, the insuloma patients, the pancreatic islet cells. So there's a couple different ones, but this one has to do with their blood sugar regulation, and so that would be bad. Octria scan should not be injected in lines that are there for parental feeding. You should use a separate IV for that. All right, so these are the acquisition parameters. Medium energy collimator, because it's indium, you have that dual photo peak. Energy windows about 20%. You do whole body planar images, and then you can also do SPECT or SPECT CT. These are the acquisition parameters for that. Step and shoot is most likely used. Non-circular, elliptical, or contouring is the orbit that you would use most of the time now. And then you do it for about 20 to 30 seconds per projection. You need to do it for a longer time per projection because indium has a smaller dose and a not great count rate. All right, next one is the MIBGs. MIBG stands for There's a really long name for it, but let's just call it iobenguane or iobenguane sulfate. And that is an analog of the guanylene, such as guanthidine and phenylthioguanidine. This is an analog of the adrenergic neurotransmitter norepinephrine. The MIBG may be used to image certain neuroendocrine tumors with overexpression of guanidines, such as norepinephrine. And the MIBG is also used for cardiac innervation studies. Neuroendocrine imaging with MIBG identifies, localizes, and evaluates a number of neuroendocrine tumors. This localizes via active transport in sites of neuroendocrine tumors. We have high doses of MIBG that may be used for certain neuroendocrine tumors, but remember that would qualify as Ezedra, and that's not really produced that much anymore. So you may have people that, if they could get away with giving a dose that is not 500 millicuries, maybe they could do it and not have to go through all the red tape and hospitalize the patient and that kind of thing. Right. So these are the indications for it: pheochromocytoma, neuroblastoma, ganglioneuroblastoma, ganglioneuroma, Merkel cell tumors, paraganglioma, carcinoid, multiple endocrine neoplasia type 2 or MEN type 2, and medullary thyroid cancer. These two you hear sometimes on drug commercials on TV, contraindicated in people with multiple endocrine neoplasia type 2 or medullary thyroid cancer. These are neuroendocrine functioning tumors, and a lot of medications will mess with that. You'll see that there are some, like, I feel like they're antidepressants or something, but you hear some of these commercials on TV that say they're not for that. Multiple endocrine neoplasia type 2 is kind of when you have more than one type of neuroendocrine tumor. Medullary thyroid cancer is just a different type of thyroid cancer that affects the medulla, and it affects the different type of thyroid cells. And it has a lot more to do with different thyroid or different hormone production, not necessarily the T3 and the T4. Assessment of uptake and residence time for treatment planning. It's also done for evaluation of tumor response to therapy. Just like I said with the Octria scan and looking at the somatostatin receptors. And then, of course, determination for high dose MIBG therapy, but not anymore, not since last year. So contraindications: pregnant or breastfeeding, recent nuclear medicine study, interfering medications. There's a whole list of them. I just have a couple of them here: antihistamines, antiarrhythmetics, alpha and calcium channel blockers, sedating antihistamines like Benadryl, tricyclic antihistamines, opioids, CNS stimulants, amphetamines, cocaine, and caffeine. So that pretty much eliminates all your illegal or recreational drugs. Those would all interfere with it. Precautions should also be taken when withdrawing any of the medications on the list. Withdrawal of drugs and replacements should be discussed with the referring physicians. Alpha or adreneuron blockers are another one that's in there. Inotropic, sympathomimetics, vasoconstrictors, beta stimulants, some nasal decongestants, even over the camera or over the counter, common cough and cold medications because they contain that phenylalanine or however you say it. Antipsychotic drugs, like depressants and things like that are on there as well. So, whole big list of drugs that you cannot take with this study. And the radiopharmaceutical is the MIBG. If it's I-123, use 10 millicuries. If it's I-131, you use 1 or 2. For children, it's a weight-based dose, 1.4 millicuries per kilogram or 140 micrograms or microcuries per kilogram. And then the patient should be monitored for any side effects. This is an adrenaline analog after all. And then I-123 is strongly preferred for pediatric patients over I-131. Another thing to keep in mind with this one is that it's iodine. What have I always told you guys with iodine? It is always going to go to the stupid thyroid. It just loves the thyroid so much and wants to be with it that it will break up its covalent bond with the radiopharmaceutical and head straight to the thyroid. Which is another problem with using I-131 tagged to anything. I-123 at least isn't going to be a therapy when it does it, but I-131 is. And so that's a problem. You have to block the thyroid as much as you can. The goal here is to oversaturate the thyroid so that the thyroid doesn't want any iodine. And that way the bond stays and the radiopharmaceutical stays bond. Otherwise, once it gets in the body, your thyroid has such that high affinity for it that it breaks the bond and the free iodine will go to the thyroid and you end up seeing the thyroid on the study. So you can give potassium iodide, Lugol solution, or potassium perchlorate. There's different doses for that. And then for I-123, you need to do it for at least 1 or 2 days to block the thyroid. For I-131, you need to do it for longer because you want to make sure it's effective because it is a therapy dose. For imaging, I-123 is 24 and 48 hours. For I-131, you can go out to 72 hours. That's probably about the only benefit of doing I-131 is that you have delayed imaging. Patients should void immediately before imaging. And then 24 hours after the injection, you do anterior, posterior whole body, followed by any planar spots that you need, and then SPECT and/or SPECT CT. Bowel cleansing may be done, and then additional 48 or 72-hour imaging may be required. Spot views are superior in image quality and are preferred in children. It's because you can accumulate for longer and you can get closer to the patient. It is recommended to start with the pelvis views so that you have an empty bladder and then move up if you need to. Some other considerations, a medium energy collimator should be used for, or could be used for I-123 to increase the image quality. And they have an example here using low energy, ultra high resolution versus a medium energy all purpose. I'm not crazy about that comparison because you're comparing high resolution or ultra high resolution to an all purpose anyway. So you know that you're already going to have a lower count rate with the low energy, ultra high resolution collimator than you will with an all purpose one. And I personally think that that's where a lot of that difference in these images comes from. But it is something that is done. The energy for I-123 is 159 keV. So it technically is still a low energy radiopharmaceutical, but you can use a medium energy if you want. Radio labeled MIBG and pentetriotide can be used to visualize different neuroendocrine tumors, and PET imaging agents may also be used. PET imaging is the way to go if you have it. If you get used to looking at these images and then I show you the PET ones to compare, you'll see that there really is a big difference. So MIBG versus octreotide. This gets confusing for our students, so I wanted to point it out to you. First of all, neither one of them are good for medullary thyroid tissue. Full stop. They're both terrible for that. MIBG was the one that had it listed on its indications, but it's not good for it. MIBG and octreotide will both localize in neuroendocrine tumors. In almost all cases, MIBG is more specific and sensitive. So MIBG is technically a better drug in almost all cases. MIBG is used to localize clinically suspected pheochromocytomas, to confirm a mass of a pheochromocytoma or to exclude metastatic disease from a pheochromocytoma. I love that word. For adrenal pheochromocytomas, the MIBG has close to 100% specificity, but it does have lower sensitivity. So octreotide can also be used for adrenal pheochromocytomas, but it has a much lower sensitivity. It can be used in cases when there's a negative MIBG scan because they're looking at different things. Remember, the MIBG is that norepinephrine analog, whereas the octreotide is a somatostatin receptor. So you may have a case where pheochromocytoma is not over-secreting that norepinephrine, but it does still have somatostatin receptors on the surface of the cell. So if the MIBG study is negative and a neuroendocrine tumor is still suspected or it's known and you want to see if it's progressed, that's where you could do the octreotide as a follow-up. In extra-adrenal pheochromocytomas, these would be also known as paragangliomas, right? Because they're pheochromocytomas outside of the adrenal glands. MIBG has a lower sensitivity for this one than octreotide, especially those that are found in the head and neck. With neuroblastoma, MIBG is more sensitive. And so it really depends on the neuroendocrine tumor that you're looking for, whether the patient should have an octreotide or an MIBG. They will both localize in both, but in the case of pheochromocytomas, MIBG is better. If the pheochromocytoma has a negative MIBG, then octreoscan can be used. For paragangliomas or pheochromocytomas outside of the adrenal glands, octreotide is better. Neuroblastoma, MIBG all day, and then medullary thyroid, don't do either. Small cell lung cancer is also one that is another consideration, and both of them will go to that as well. And MIBG in the past has been a little bit better for that one. So MIBG, pheochromocytoma, and neuroblastoma, octreoscan, pheochromocytoma when it's outside or when MIBG is negative, and then octreoscan is actually a lot better for carcinoid as well. Now we'll talk about the PET agents. You have your copper 64 dotatate and then your gallium dotatate, DOTATOC, and DOTANOC. This is a comparison of the two. If you guys recall from PET class, we talked about which one has better sensitivity and specificity and all that jazz. The imaging characteristics for copper are better, but copper still has some disadvantages. So each will have some benefits and disadvantages. Remember, if you're performing PET imaging and your doctor specifically orders one, these are not like generic drugs where you can substitute one for the other. This is like Coke and Pepsi. And, people get really specific about which one is better and which one they want. If somebody wants Pepsi and they only want Pepsi and you give them a Coke, they're going to taste it, they're going to know, and they're going to be mad. If the doctor orders Detect Net and you do Net Spot, that's technically an error. You can get in a lot of trouble for that, for not doing the test that was ordered. And your institution where you're working can get in huge trouble for that. Especially if it's like Medicare, that's technically Medicaid or Medicare fraud, especially if you get paid more one for the other, or the company's reimbursing you for doses and things like that, you can get in big trouble. So you got to do the one that's ordered. If they just say neuroendocrine imaging for PET, you can use either one, but if it specifically says on the order, you can't. So copper is going to have, this is the same patient, by the way. So this is patient 1, top and bottom with both drugs. This is patient 2 that got both drugs. Patient 3 that got both drugs. Yeah, you get it. So in patient 2, I want you guys to look at patient 2. See how this is the exact same patient, but you have a lot more spots showing up with the copper. Look at the face, the chest, Look over here just above the liver. Look over here on the right side, especially. Even in the axilla area, you see more spots, and the spots that you see are showing up darker. Now, that's because copper does not travel as far before it annihilates. It has a smaller positron range than gallium does. And so you're going to have more concentrated counts closer to the annihilation event, which allows you to have better spatial resolution, and it allows overall for the test to be more sensitive. That's why you're seeing more with copper. Copper has a higher radiation dose, poorer counting statistics because it has a longer half-life, but it has better detection abilities than gallium does. So just different differences to keep in mind. Lower radiation dose to the patient, but if it was me, I would want the test that's going to pick up more of the cancer spots and show better sensitivity and resolution, and I would just take the hit on the radiation dose because I've had enough in my life anyway. What's one more little gray? So that would be me if it was, if I was the patient, but you do have a lower radiation dose with gallium. It is more widely available, blah, 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 things like that. So indications for all the dodatates and dodatox and dodanox. This is initial staging at diagnosis, localization of a primary tumor, staging before surgery, selection of patients for peptide receptor therapy, that's Lutathera. And then also it serves as a baseline and a follow-up after their therapy. Some neuroendocrine tumors have lower expression of somatostatin receptors, and therefore imaging using F18-FDG may be more beneficial. And neuroendocrine neoplasms are broken down into neuroendocrine tumors and neuroendocrine carcinomas. So NECs. We've only talked about NETs. We haven't talked about NECs. But the loss of somatostatin receptors and uptake on FDG may indicate the progression of the disease. So same thing that I just talked about a little bit ago. As it progresses, you get more tumor heterogeneity. It starts to lose some of its somatostatin receptors. And at that point, it's pure cancer cells and they will take up sugar. Patient prep is to discontinue the short-acting somatostatin analogs for 12 hours, long-acting for 3 to 4 weeks. There has been some discussion over these guidelines in the past because different drug companies may recommend something slightly different. And I'm sorry, did I say 12 weeks? I meant 12 hours. I don't know what I said. I'm too tired. But there are slightly different regulations for like DetectNet versus NetSpot or DotaTate versus DotaTalk. And so you want to read that very carefully. You may see where this is slightly different in different publications, but it's going to be about the same if you really think about it. The short acting ones don't need discontinued for as long. Some places have said up to 24 or 48 hours. And then the long acting ones need withdrawn for longer. Some places may have published up to 6 weeks. 3 to 6 weeks makes a big difference in the patient. And so you'll follow your facility guidelines for that and just know that those need to be removed for a period of time. About a month if it's long acting, about 12 to 24 hours if it's short acting. This is safe for pediatric patients, but you may need to sedate them. And then if patients are breastfeeding, you'll discontinue for 24 hours after the injection. So DotaTalk is Octavi. That is on the pending FDA approval. This is what it will be. I don't think it's approved yet. It takes a while for that, but it already has the doses and the protocols and everything all worked out for it. DotaNoc is not FDA approved yet. NetSpot and DetectNet both are. I have used NetSpot and DetectNet. They're both pretty cool drugs. Copper's a little bit of a pain in the butt to work with, but it does produce better images for the patient, and it will expose you to a little bit higher radiation dose as well. And it just can just stay in your department for a while because it has longer half-life. All right, so protocol, I don't know why it's written like that. Let's just go with it. The uptake time post-injection, roughly about an hour for all of them. Now it says 55 to 90, 40 to 90, 45 to 90. Most of the time we just cut it right down the middle and be like, okay, about 60 minutes, because then you're good no matter what. Especially if you're at a facility where you're using dotatate and the gallium dotatate and the copper dotatate. It's just easier to keep them straight if you keep the same protocol for both as far as the uptake time. Now, copper has a longer half-life. It's 12.7 hours versus 68 minutes for gallium. And so later imaging point with copper may be needed. So what that means is that you may need to do those patients in the afternoon. During uptake, the patient can drink and void as needed. Some protocols administer low osmolality oral contrast for GI neuroendocrine tumors. And if that happens, it's kind of the same as you do it for the FDG studies. You use about half a container of the oral contrast, mix it in with about 16 or so ounces of water, crystal light, anything like that. To scan them, you will do a scout, CT, and then PET. So you scout to map out the scan parameters for the CT, and then it goes right into the PET scan. You scan typically vertex to thigh, vertex to mid thighs, like eyes to thighs, like we do for FDG. But some neuroendocrine tumors may require that the total body is scanned from vertex all the way to the toes. You can see that with like carcinoids, neuroblastomas may require that. What else have I seen with that? That's all I can think of off the top of my head, but wherever you're working, a doctor will tell you. All right, so Scout CT PET. That's what it almost always is for PET anyway. For liver metastases, IV contrast can be helpful only if you're giving diagnostic CT, and then water should be used for the oral contrast if that's the case. The scan, I just said all that about vertex to thighs. It's scanned in 3D mode. It's about 3 minutes per bed position, but you may need 4 to 5 minutes for copper 64. This is somewhat slightly dependent on the scanner that you're using also. If you have a newer scanner or it's digital, you can go for less time. I did copper 64 and the dotates on a digital PET, and we did 2-minute bed positions with gallium and 3-minute bed positions with copper, and the pictures were beautiful. So if you have a digital PET, you can shave that time off of there. You can reconstruct them with 2-millimeter slices in the sagittal, coronal, and axial views, about 3 millimeters max. All right, so somatostatin imaging protocol. Preparation is all of that stuff you see there. No somatostatin recepting analog drugs. Those are done to control their symptoms, and it's very difficult for the patients. If patients are on a long-acting somatostatin analog and they can't go 5 weeks without it because their symptoms get too bad, they can be switched to a slow-acting one for a period of time, and that way they only need to withhold the medication for about 12 hours. That is usually doable for most patients, even the ones that have a really hard time. If they can switch to slow acting for a while, that is helpful. Administer the dose, 4 millicuries for DOTA-TOC, weight-based for gallium dotatate, or it's about 3 to 5 millicuries. And then for copper, it's 4. Uptake for about 45 to 90 minutes roughly. And then encourage them to hydrate, have a low iodine oral contrast for GI neuroendocrine tumors, and then scan the patient 3 minutes bed position for gallium and 4 to 5 for copper. And it's usually vertex for thighs. Remember, you do scout, CT, and then PET. All right, so what's the difference between all these dodatates, dodatots, dodanox? They will go to different somatostatin receptors. There are 5 different types. We talked about this in PET, so you might want to go back and review it, but there are 5 different types. The DOTATOC that's pending FDA approval only goes to somatostatin receptor 2 and 5. DOTANOC, which is not used here in the US, it's not FDA approved yet, but in Europe and all those glorious places they use it. This is binding to somatostatin 2, 3, and 5. Dotatate, it binds to the somatostatin 2 only, but with a higher affinity, about 10 times greater affinity. And then the dotatate, only it's the same dotatate for copper, same dotatate for copper and for gallium, and for lutetium. Dotatate is dotatate is dotatate. It's the same one, just tagged to different things. So for DetectNet, it's the same thing. It only binds to the somatostatin 2 type, but it has a higher affinity than the other ones. It has a 10 times higher affinity. So with gallium, you have a lower dose to the patient, lower background uptake, and faster uptake, only by like 5 minutes, let's be honest. It's not that big of a deal. But the copper 64, lower effective positron range, so better spatial resolution. You have a higher SUV max, less labeling time, but higher labeling efficiency. It also has a longer shelf life because you have a longer half-life. And so it allows for more flexibility in your schedule. And then it requires a higher dose, though, to get the same counts. So higher dose to the patient, lower count density, which is why you take the images for longer, right? So this is another chart just comparing the two. You see that the effective positron range is 0.56 millimeters for copper, but 3.5 millimeters for gallium. That little positron booger travels pretty far before it annihilates, and that can really degrade the spatial resolution, the ability to find small, teeny neuroendocrine tumors. All of that stuff gets degraded. One of the bad things about copper is that it also gives out a little bit of a beta, whereas gallium is pure positron, almost 11% is electron capture, but it's a very high amount of positron and doesn't have any beta. If you look at copper, only 17% is actually positron. You get a lot of electron capture in there, which is also how you're getting more background, right? The electron captured photons might still be picked up. They're still scattering within the patient. They're contributing to stuff even if you're not really seeing them. And so this is a diagram showing you lower energy, shorter range positron emitters provide better spatial resolution in PET, and it's showing you why. You know, they travel. What we're actually imaging in PET is the annihilation reaction. If it's too far from the positron, then we're tracing it back to the soft tissue where it's scattered to, and that might be pretty far from where it actually annihilated. No, yeah, where the positron came from. Just, you know what I meant. Okay, so you have a high range positron emitter with the gallium. It goes very far before it annihilates, so it's more spread out, so you can't trace it back to where the positron located as well. It also, because you don't have as good a spatial resolution, it's less intensity in the pixels and it's spread out over more pixels when it doesn't need to be like that. So this is an example of the Lutathera that is used for the therapy portion of it. Remember, that's our theranostic for all of these neuroendocrines. Since we don't really have MIBG high dose anymore, this can also be used in conjunction with the Lutatheras, but a lot of doctors will require the actual PET study first to make sure it's going to go to the somatostatin receptors. It really should be a somatostatin receptor agent first, not the MIBG. but MIBG might be their first step, and then it progresses to the PET study. This is showing the same patient here. Patient A is pre-therapy with gallium dotatate, and then B is the treatment. You can image after a Lutathera, and this is often done just to make sure that it actually went to the same sites and that actually got taken up by the tumors, and there's no infiltration or anything crazy happening. And then the post-therapy follow-up with gallium, a month later, it really responded to that, didn't it? So this is why we would consider this more curative, because that looks like it cured it to me. It's what happens though is that it treats the symptoms, alleviates the symptoms. It treats the neuroendocrine tumor. It is beta, so it will kill some of the cells. But those neuroendocrine tumors are very slow growing. And so it might just knock them down for a while, not really cure it, or it may change them and morph them if it becomes really aggressive, or really advanced neuroendocrine tumor. The cancer may respond by getting more heterogeneity and getting more aggressive. That happens a lot with cancer, where you treat it with therapy and it knocks it down, but then it comes back with a vengeance. And so that's why a lot of times the dotatate is considered to have a palliative nature to it. But it does treat it. So Lutathera, the treatment is for gastroenteropancreatic neuroendocrine tumors. I said that real slow and weird to break it down for you. Gastro is stomach, entero is small intestine or intestines, and pancreatic is your liver. Just kidding. Pancreatic is your pancreas. So this is telling you anything in the GI tract, right? It's considered foregut. Foregut is kind of a misnomer because it talks about the development in the fetal stages. So your lungs are considered your foregut, just because of how the fetus develops. And so it is used for small cell lung cancer because that's considered foregut. Not widely accepted or used for that, but it will go there. So it has a half-life of 6 days. It's a somatostatin analog. You guys already know about Lutathera, I think. This is the treatment plan for it. 8 weeks in between, and they get 4 doses. And then they're also placed on long-acting octreotide. That also helps to control it because it blocks the uptake, or it is a somatostatin analog. So that's helpful as well. And so the dose is 200 millicuries every 8 weeks for a total of 4 doses. By the time it's all said and done, that patient has received 800 millicuries of lutetium. That's a lot. There are also other medications that are given with this that you need to know and understand. So the antiemetic, typically Zofran, is used. It's a great drug. Aldosterone is the name of it, I believe, but Zofran is the trade name. This is usually done to control nausea in patients that have cancer or some advanced disease that they're nauseous a lot. It's a great drug, no side effects, knocks the nausea right out. But this is given 30 minutes prior to the amino acid solution. The reason that we give that antiemetic is because the amino acids will make them nauseous. So we give the antiemetic 30 minutes before the amino acid so it has time to kick in, and they're not going to be nauseous when we start giving the amino acid. The amino acid solution is given to protect the kidneys from the really high radiation dose. Lutathera is excreted primarily in the kidneys, so kidneys and bladder end up getting the highest dose. And so we want to protect those precious little kidneys from radiation, and the amino acids help do that. They help them heal. And then after the therapy is given, a long-acting octreotide is added, and this is done to help control the symptoms as well. So they get 3 adjunctive medications with this one 2 of them before the Lutathera and then 1 after. So this is the protocol. Antiemetic is started, and then about a half hour later, the amino acid is started. That amino acid hydration runs for about 4 hours, but partway into that, the Lutathera is given, and the amino acids are L-lysine and L-arginine, and this is done to decrease the reabsorption of lutetium through the proximal tubules and decrease the dose to the kidneys. So it's protecting the kidneys. Now, Lutathera is usually given through this like reverse gravity method. And so this is the setup that's used a couple different ways. In image A here, it's the use of an infusion pump. This is 200 millicuries of a beta emitter, and it gets infused slowly. You're not going to sit there and hold it the whole time. That would be completely stupid and against ALARA. So we use a gravity method or we use an infusion pump. The infusion line is filled with Lutathera using the infusion pump, and then the connection of the infusion line to the saline bag for line flushing. Now, in image B, that's the gravity method, and basically you have the direct infusion where it's your vial is here. You have saline running through one line to the patient, and then in this line, you have this little air filter to pressurize it. And then you have basically, this is going in, okay. This is going in this way, and it's kind of forcing it in that way. So it's like sucking it up into the line, and then it goes to the patient. It's like a, what's it called? Vial purge. Oh, it's written right there. It's called a vial purge. All right, so this is showing you the gravity infusion method. So you have the saline. It will be 1 drop every 3 seconds, kind of a steady drip for the first 15 minutes, and then you turn it up to the maximum flow rate after that. You have a short needle, and you'll see the short needle has to stay above the level of the liquid. That short needle is inserted after the long needle, and it should not touch the Lutathera solution. Then you have a long needle. The long needle goes all the way to the bottom. So the short needle is displacing the fluid and filling the vial with saline. The long needle is sucking the Lutathera out. So the theory behind this is the pressure in there is going to force that Lutathera liquid into the long needle, and then it gets sucked up and delivered to the patient, and the liquid in the vial eventually gets replaced with saline, and it washes out the vial. And so that's the basic premise there. Patients will have 2 IVs. One is their amino acid solution that's protecting their precious little kidneys, and the other one is the Lutathera that's zapping their kidneys, or should say zapping their neuroendocrine tumors. That's what we really want. A survey meter is also placed there to measure the exposure rate, and then the Lutathera is typically placed into an acrylic dose vial. I have seen where it is in a lead vial, but it should also be behind plexiglass. Kind of should be plexiglass then lead, if you ask me, but whatever. They use both because you have beta and then you have like gamma and whatnot as well. For lung, you don't want that. So this is the way I've seen it done. I actually took this picture. This patient was very nice to let me take pictures. But this is how it goes down in. Short needle, long needle going to the patient. Couple things with this gravity method. One, if this pressure gets unequalized in here, then it's going to spit out these needles and you could get a spill of Lutathera. If the IV is not working, then the pressure builds up in the vial. The saline will continue to drop in there. The pressure will build up and it will push the needles out. So you want to make sure that they have a good IV. If it's in the AC, they need to keep their arm kind of extended and make sure that they're not bending their arm because that can stop the IV or even slow down the IV so that that pressure builds up in the vial. You also, if that happens, then you run the risk of the Lutathera volume growing higher and higher and higher, and the short needle will go into it, and now you don't have that displacement gravity thing going on. Now you just have a mix of saline and Lutathera on there, and it's all, you might as well just pull it out and inject it into the patient because that's not working. So that's how that works. And then once it's done in the vial and the Lutathera is gone, then you can up the saline, and then it just kind of flushes everything out. So this is done to look at the dotatate efficacy, pre-therapy, 3 months, 9 months, and 12 months follow-ups. And this is either done with the gallium or the copper. That's it for neuroendocrine tumors. That's the theranostic agents for that. Now we're going to talk about breast cancer. There's a couple different things with breast cancer. Some of these are just oncology, and some of them are, no, they're all just oncology. There's no therapy for it. So lymphoscintigraphy is for breast and for melanoma and for head and neck. And then we have symptomammography, which is the Meriluma sestamibi one. And then we also have fluorestradiol using PET. So I do want to point out that breast cancer patients get a lot of testing. They also will get MUGAs if they're on a chemotoxic chemotherapy or cardiotoxic chemotherapy. They'll also get bone scans pretty regularly. So they get a lot of stuff, and they get FDG studies too. So it's not like we don't have things for breast cancer patients. We just don't have a theranostic for them. Okay, so rationale for lymphoscintigraphies, looking at sentinel nodes for breast cancer or melanoma. This provides a map for surgeons during surgery. And what we're looking for with a lymphoscintigraphy is the sentinel node. Essentially, a lymphoscintigraphy can be done on any cancer that spreads through the lymph, because all you're doing is injecting and watching the lymph flow. So these soft tissue cancers like breast cancer, melanoma, head and neck cancer, vulvar cancer, which for some reason we see a lot of in Florida, all you're doing is looking for the sentinel node. You're looking for that first lymph node that the tumor is going to drain to, because that's how the tumor is going to spread. And you biopsy that tumor, and then that gives them a lot of information on whether that tumor has started to spread, is likely to spread, and it determines the treatment plan, right? So if it hasn't started to spread, that sentinel node is good to go, then they may back off and not do an aggressive therapy for that patient. But if it is already present in the lymph node, then we know that cancer has started to metastasize. They're more likely to be more aggressive at doing like a preventative round of chemo or things like that. So the radiopharmaceuticals that we use are sulfur colloid, filtered or non-filtered, and telmanacept, which is brand named Lymphoseed. So for telmanacept, this was FDA approved in 2013, so it's been around for a hot minute. The dose is 0.5 millicuries, average size is 7 nanometers. Uptake mechanism is not dependent on particle size. Method of localization for this one is receptor binding. It targets those receptors on the surface, the mannose receptors that go into the lymph nodes. So it takes the telmanacept into it, thinking that it's mannose, and it will kind of sneak in there and it will stay within the lymph node. This is different from sulfur colloid. Sulfur colloid is compartmental. So sulfur colloid just follows the flow of lymph. You can miss the sentinel node with sulfur colloid and get like nodes further down the chain, which can be bad. You can get a false negative that way. But the telmanacept will go straight to that first one and stay there. It also has a small size, so it has rapid clearance from the injection and the soft tissue into the lymphatics. Critical organ is the injection site. It expires in 6 hours. The procedure for that, all of these, sulfur colloid and lymphoseek, the physician or appropriately changed individual is an understatement. They really have to get that injection right. They really have to know what they're doing, or else they screw up the whole study and they don't get accurate results for the patients. So it has to be injected just under that first layer of skin, like a TB test. You guys, I think, have all had TB tests at some point by now. It goes just under the skin, bubbles up the skin, and then it will get into the lymph system that way. But if they go too far, it takes longer for it to get into the lymph node. It will go into the soft tissue, and it may follow a different lymphatic tree once it actually gets there. So they have to do it the right way, go just under the skin, or else they screw everything up. With breast cancer, the injection should be placed 1 centimeter from the edge of the tumor. With breast cancer, now I'm sure there's a lot of research on this, but it seems really crazy to me. There's not enough definitive research saying that this actually helps. There's research saying it does and research saying it doesn't. Some doctors will inject around the nipple or even right into the nipple. So if you have a large breast and the tumor is on the side, like by your armpit, they will still inject in the nipple. That does not make any sense to me. But they should inject around the edge of the tumor, and then some doctors will also inject around and into the nipple. And for melanoma, goes just under the skin and like clockwork. Each of these is like clockwork, or what they call like a wagon wheel. And basically, it's like 4 small injections at like 12, 3, 6, and 9 o'clock. If you're looking at a clock, it's in a circle. And then it goes right around the tumor site that way, and that should drain to the sentinel node. So with melanoma, divided into 4 to 8 doses with 0.1 milliliter each, very small volume of at least 100 microcuries each. You need enough of activity that you can actually pick it up by your camera. So it needs to be at least 100 microcuries, but it needs to be a very small volume. And then you'll cover the injection site with a bandage or gauze. For the breast, you want to have the patient with gloved hands massage that area. A lot of times they will put like chucks over it, and then have them massage it gently with their hand. That helps encourage it to get from the tissue into the lymph. Also, putting a warm blanket on them, the heat actually really helps to move your lymphatic system. So do that. And you want to cover the injection site with bandage or gauze. Imaging should begin immediately after injection with sulfur colloid, and then 15 minutes if you're using lymphoseek. Lymphoseek's going to take a little while to get there, but sulfur colloid is compartmental, so it's going to go there quick. You can do a flow with sulfur colloid. With lymphoseek, it takes a minute. Imaging is performed in 2 phases. You can do delayed imaging if you really need to. You mark the location typically with a surgical marker on the skin. Sometimes the doctor has to do that, but whatever. And then be sure that the images are available in the operating room with the patient. Some protocols will not do imaging at all. I hate that, because I'll tell you why I hate that. Now, in some cases, it might be okay. I have done a breast lymphoscintigraphy before. We injected it, doctor injected it, actually did a good job. And then this was like, your breasts are anterior, right? We did imaging, and this lady had sentinel nodes, multiple sentinel nodes that went to her neck, her armpit, and her groin. And the surgeon decided to remove all of them because it was a type of cancer that's known to be a little bit more aggressive. And he was concerned, and he biopsied all of them. If you don't do imaging, most people would just look in the axilla for those sentinel nodes, and he would have found some, would have completely missed the lymph nodes in the neck and in the groin. And I have seen melanomas in the back where it went both ways. And so your lymphatic system can be kind of complex. I like taking images. I think that's best for the patient. Some people don't because they're lazy and it's easier not to. And some doctors don't look at them because they just use the intraoperative probe in surgery, which is great. It's great that you have one, but if you don't know where to look, you might miss something. So that's my soapbox on that. These are some images of the melanomas. So with A, this is showing a single channel from the right arm to the right axilla. With C, I'm just going down the first row here. C, you see two channels in the upper back that go to the left axilla. And these are the channels here. Boom, boom. This is the injection site. Here's the one where it's an A. E, you have several channels. So boom, 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 leading to the sentinel node. And then in G, you have two parallel channels from the lower extremity, each draining into the right groin. So you have two sentinel nodes for this patient. Now, H is exactly what I was talking about. This is somebody in the back, and it went both sides. If you don't do imaging, you just look at the armpit, you're going to miss one of them. And that one might be positive for cancer. So this one is in the back. It went both sides, boom, boom. I've even seen the back where it goes boom, boom, both sides, and then also goes to the groin. With F, this is a changing drainage pattern from the left anterior chest to the sentinel node in the left axilla. And then I saved these two for last, B and D. D is multi-channels. That's not that exciting. We already talked about that. I mean, it is, but B is the one where I want to point out. Notice in all of these except for B, you don't see the body outline. So if I didn't tell you what anatomy we were looking at, you would have no freaking clue. I mean, E looks like a falling star. H looks like a crab. I don't know. G looks like a bad firework. I don't know. They look different, right? And you can't really tell the length of them, like how big the picture is, how big of an area is covered. You can't tell the anatomy of what you're looking at because there's sulfur colloid and the tilmanocept are not going anywhere else in the body. They're confined to the lymphatic system. So you have no other counts that you're imaging other than the lymphatic system. So you don't see a body outline. You have no clue where you're at. This is why transmission scanning is so important. So B is showing a transmission scan where you can actually see the body outline. Now you can see that you're looking at somebody's head and neck, right? But if you were just looking at B, like this first image here, you would have no clue where you were looking. That could be anywhere. It could be anything. But having that transmission image really helps you see that anatomy. And I have that on the next slide. A lot of times to do a transmission image, you can just hold your normal cobalt sheet source that you use for a flood between the patient, behind the patient and the camera. So you have like camera, patient, and then the source, right? You're putting your patient between the flood source and the camera to purposely attenuate your flood source so it creates this outline of the body. So you don't hold it there for very long. Just like a couple seconds is all you need just to create enough of a contrast that you can see where you're actually looking at. And for this one, it's either subtracted digitally or there is lead over the injection site. Because of the complete absence of counts, I think it's removed digitally, but that's pretty common too because it's so hot, you might not be able to see the lymph node until you cover the injection site. That's it for lymphoscintigraphies. Make sure you know the doses and all that jazz for sulfur colloid and tilmanocept. Now, for breast imaging or symptom mammography, this is not done very often. We also have PET breast imaging. Those use a special scanner too, and they're not widely used. But when with the sestamibi, cannot be called cardiolite because we're not using it for the heart. We're not lighting the cardio. We're looking at the breasts, so it's called miraluma now. And tetraphosphamine, even though it will go there, it's not FDA approved, so you cannot see it. Tetraphosphamine made by GE. They're cheap. They never did the paperwork or spent the money to do FDA approval, and that's why it's not FDA approved. Cardiolite is can be off-label now, but it's made by Cardinal Health. They actually did invest in it because they thought it would be a great breast imaging agent, and it does have the potential to do really great things, especially if you're doing solid state imaging and you're not using a regular PM tube gamma camera. Then you can really get great pictures that are pretty much as good or better than mammography. All right, so sestamibi is lipophilic and cationic. The exact localization in malignant breast cancer is unknown, but these are fattier tumors. It's adipose tissue that your breast is adipose tissue. So it's believed that might be something to do with it. Maybe it's the cationic part of it. Nobody really knows. These are the acquisition parameters, pretty similar to all tech-based agents, but the patient positioning is different. Patient will be prone. There is a special cutout cushion or holder that's used for this study. There's also dedicated cameras. You can use a DigiRad, or there's other dedicated small field of view cameras that look kind of like a mammography machine, but they're gamma cameras that are used for this test as well. Pictures are about 10 minutes each, and that's kind of it. Everything else is basic, same thing as most tech-based agents. So the protocol, you inject the patient in the contralateral arm. This is important. You want to do the opposite arm as the suspected cancer. Wait 5 to 10 minutes and then put them prone. This is the holder for it. I feel like that holder's not great, but sometimes what I have seen other people do is the patient just kind of shimmies up, or they use like whatever they use for prone cardiac imaging, or with some of these cameras, you might be able to place their head slightly different, but still have their breasts kind of free hanging. And that creates an even better separation than the holder. But the point is, you want gravity to work with you, so they're prone, and then you want the breast to be able to hang so that they're separated from the chest wall. So A is mammography of no value. B is a positive miraluma, and this patient had ductal infiltrating carcinoma. I shouldn't just say mammography of no value, but it is. The breast is really, really dense. Remember, mammography is x-rays. So if you have breast or dense breasts, then it's going to show up as whiter. It's going to be more like calcified looking. And the whole way that you see if somebody has breast cancer is because it looks whiter. That cancer is denser than the normal fat tissue. If they have really dense breasts or fibrous breasts, it's going to already show up looking very white. And then we won't be able to see, it'll mask any cancer that might be there because we don't have that contrast in the image anymore. If they have breast implants, the implants will attenuate and we won't be able to see what we need to see on mammography. And if the patient has had prior surgeries and they have a lot of scar tissue in the breast, we also cannot see what we need to see. You'll get false positives and false negatives with that because that scar tissue will appear white the same way that a tumor would. The miraluma, though, this is The arrow's pointing to it. This is a crappy image, but you see that there is some maryluma that got taken up. Maryluma won't normally go to breast tissue unless there's cancer there. So this was ductal infiltrating carcinoma, and the tumor's right there where my laser pointer is. This is fused images. The mammography is right here on the left. Maryluma study is in the middle, and then it's a fused image. This was biopsy due to a palpable mass. The circle is the place that was questionable on the mammogram, right in here. And then it didn't show up on the maryluma, but we have this whole big thing up here that got completely missed because you had all this fibrous densities up here. And so then when we fuse the images, we see like, hey, oh, there's a tumor right there. This was lobular carcinoma in situ. Situ means earliest stages of cancer. The cells are just starting to become cancerous. That's when you want to find the cancer and remove it. So this was really lucky that they had a suspicious nodule that ended up being nothing. And then because they had some densities and stuff like that in there, they got a maryluma study and it showed them what they needed to know. Otherwise, this cancer would have got completely missed for a period of time. Now for fluorestradiol. This is detection of estrogen receptor positive, ER positive lesions as an adjunct to biopsy in patients with recurrent or metastatic breast cancer. This does not replace other imaging or biopsy, and limitations of use. The tissue biopsy should be used to confirm recurrence and verify ER status by pathology. And Cerianna is not useful for imaging other receptors, such as the human epidermal growth factor receptor 2, the HER2, or the PR, which is the progesterone one. So only estrogen positive receptors, estrogen receptor positives. Contraindications, it's not in considerations. It's not useful for imaging other receptors. Literally just said that. Also pregnancy. Recent nuclear medicine studies, it's very dependent on the radiopharmaceutical and the half-life. Most of them are going to be okay. Breastfeeding, they want to pump and waste the milk for 12 hours. And then systemic endocrine therapies may reduce the detection of the positive lesions, and it's not useful for the HER or the PR. Some of the estrogen receptor modulators and downregulators will block the estrogen receptors. So long-acting ones will need to be withheld for 28 weeks. Short-acting ones like tamoxifen, that's a very common one, they need withheld for 8 weeks. And then perform the FES imaging before starting the ER blocking receptors. You don't ever want to delay a patient's therapy to get their FES scan. So the correct treatment there, or the correct protocol there, is to do the fluorestradiol study before they get started on those therapies. And then I think that's all I was going to say about that. Those are the protocols. It'll differ slightly whether you have GE, Siemens, or United Healthcare. GE, you're going to do 2D. Siemens models and United Healthcare, you're going to do 3D. Bed position is typically vertex to thighs. Breast cancer can spread to the brain, and you can get bone mets in the skull. So we do the top of the head all the way to mid thighs, and whole body if they have known mets in their lower legs that was seen on other imaging, like a bone scan. Energy windows about 30-ish% on 511 keV. Uptake is 20 to 80 minutes, and the dose is about 6 millicuries, but it's given over 1 to 2 minutes slow infusion. Patient needs to hydrate and void. I have seen where it's kind of recommended to wait a little longer to get the best quality images, but the uptake time is about 20 to 80 minutes. This is the normal biodistribution. Liver should be the highest. Urinary tract, because it's renal clearance. Uterus will be there because there's estrogen receptors all up in there. The low level uptake of the low estrogen receptor accepting tissues like the lung and the white adipose tissue. These are some image findings. Remember, the patients will benefit from both studies. So we've talked about this with other ones. Breast cancer is really bad about heterogeneity, especially as the disease progresses and gets crazy cancerous. Those cells will lose their estrogen receptors. They're no longer functioning like estrogen recepting cells, and they're now just functioning like cancer cells, and they're taking up sugar. So that is very important to think about. Patients should get both, and they should get both. If you see that the patient is like this one, where they have a lot of activity on the FES PET, that's good. They can benefit from hormone recepting therapy, especially if their FDG doesn't look too bad. But if you get to a point in the same patient where they no longer have a positive FES PET study, but their FDG study, like imagine that these flip-flopped, that's really bad. That means their cancer has now progressed. The estrogen receptor therapy or the, hormone replacement therapies are not going to work for them. And so, or the hormone therapies, I don't know what I'm saying. But the hormone therapies are not going to work for them anymore. Now they need something a little bit more aggressive, or they're going to progress more towards palliative and hospice care at that point. All right, so prostate cancer, I think this is our last one. Prostate cancer, one thing I want to point out, do not forget there's a difference between PSA and PSMA. So PSA is a secretory, let's read it, it's a protein. Its a known function is liquefaction of semen. It's measured in serum as a cancer marker, and it's decreased with androgen deprivation. PSA is prostate specific antigen. It is something that has a known function on our body. It's just to liquefy semen. That is not something that women typically have. That is something that is specific to a certain purpose in men only, and stays in the prostate. That's what it's where it's working is on the male sex organs. If you have your prostate removed, you shouldn't really have a PSA, or should be very low. If the PSA starts to rise after they've had their prostate removed, or after they've been treated for cancer, that's a blood test. If that PSA starts to rise in their blood work, that is not exclusive to, but it's suggestive that their prostate cancer has metastasized, has returned. So that's a blood test. PSMA is very different. PSMA is a membrane protein. It has several functions in our body. It's a terrible name because everybody has PSMA in their body. It's also has to do with folic acid absorption into the cells. That's one of the enzymatic functions of it. It's acts on your glia cells in your brain. So PSMA is overexpressed in gliomas. It's overexpressed in female cancers as well. And there are a lot of different cancers that overexpress PSMA because it has to do with folic acid. The cells are going to take up folic acid as they're taking up nutrients and stuff and growing and becoming nasty cancers. So it's in everybody. And it's not something that you can test for. It's just something that's in your body. It is upregulated in androgen deprivation, and people that have prostate cancer will have more of this membrane protein. The they'll have more of these receptors on the surface of the cell. So this is what we use for imaging because we know that this is a membrane protein that these cancer cells are going to overexpress. So we take a PSMA and we tag it to radiation, and when we inject it into the patient, we see all the places PSMA goes. And so we can see the cancer cells, we can see the metastases, but only as long as the cells are overexpressed. They start to become more and more like cancer cells, more and more um, undifferentiated and less specialized and more like a cancer cell. They're going to lose those PSMA receptors on their surface. And at that point, they're going to take up sugar. But we catch it early, PSMA we can actually use for therapy as well. Expression does correlate with cancer aggressiveness and represents an independent indicator of poor prognosis. So, as it starts taking up more and more and more PSMA, that's when we know this is an aggressive cancer. It's got all these PSMA receptors on it. It's really aggressive. It's growing. It's a nasty cancer. And then it stops doing it. Now it's really bad because now it's taking up sugar. But in that before stage where it's aggressive and it's growing and it's overexpressing PSMA, that's when we can see it and when we can treat it. So this is the spectrum of imaging modalities that's used. I stole this slide. That's a picture that I took at a meeting. Obviously, Lantheus gave the talk, but this is showing the increasing progression of the disease and how different imaging fits into it. And so this is why I wanted to share this with you guys. I think you've seen this slide before. So transrectal ultrasound is great early on. That's going to help detect the cancer and find it at the early stages. So you have the digital exam. If they find anything where it's suspicious, you'll do the transrectal ultrasound, and they'll look at the prostate to see if there's likelihood of prostate cancer, right? Then they're going to get like biopsies and whatnot. CT scan uses a series of x-rays, right? That provides great detail about anatomic structures. You can see the prostate. You can see density changes and things like that. You can see the size of it, shape of it, all that good stuff. You're only going to see tumors, though, that are structural, where you can actually see them on the x-ray. Multiparametric MRI. This is made for up to 2 or more MRI modalities. MRI is going to give the best detail in the structure and the anatomy, and you can really see a lot of fine detail in the soft tissue. But again, you're only seeing structure, right? You can see localized inflammation. The cancer is going to cause that, so you can see if there's inflammation around it, size of it, density of it, all that stuff. Once we know it's cancer, though, nuclear medicine is really the best because we're seeing functional stuff. So PET CT scan, that's where we can do PSMA and FDG and Axumin, right? We also have fluciclovine. There's also like C11 choline. I'm not talking about that because it's not really on your boards, but it is FDA approved. Super short half-life. It's only going to be used in research facilities because the half-life makes it too difficult to really manufacture or use. So we have fluciclovine, we have FDG, and we have PSMA in our prostate scan arsenal. We also have bone scans. Bone scans are used later stage once we know that it has metastasized to the bones. That could be MDP or it could be sodium fluoride. But bone scans show any differences in the skeleton, which are indicative of cancer. That really dumbed it down for you. If we just talked about bone scans, you guys know what they do. So we have, once they know or they suspect bone mets, they get a bone scan. Initially, they can get FDG and PSMA as a baseline when they first get diagnosed. That will help determine their treatment. Fluciclovine is used if their PSA numbers start to rise and their bloodstream, and we suspect that the cancer may have returned. So after they initially diagnose them, they get the FDG and the PSMA. They'll probably get a bone scan at that point too, just to look baseline and see where they're at, determine their treatment plan. Let's say they had no bone mets, they got castrated, and now they're doing good. But a couple years later, their PSA level starts to rise. That's when they would do fluciclovine and probably repeat a bone scan. And then depending on what those look like, they may go to PSMA and FDG. If the PSMA is positive and it looks like there's metastases, this is when they may qualify for Pluvicto. And so that's the progression of it. They can also get bone scans to follow up to see if what the bone mets look like, all that jazz. So fluciclovine, patients will be NPO for 4 hours. Exercise should be avoided for 24 hours. Image acquisition, wait time is only about 3 to 5 minutes after injection. Super fast uptake time. Fluciclovine is an amino acid, so it's going to localize completely different. And it's going to find things more than PSMA will. PSMA is not always going to be there, but the amino acids almost always will. A lot of these tumors will take up amino acids because they're using them to grow, metastasize, all of that. And they may not be aggressive enough that they're taking up sugar on FDG. So fluciclovine and FDG are great for that. If we know the patient has metastases, then we want to do a PSMA study because we want to know if it's going to take up Pluvicto and if we can treat it. And if it's taking, got a lot of PSMA receptors. Field of view, mid-thigh, and then go up to the base of the skull. We do them backwards because we don't want activity in their bladder, so we do the bladder first. Have them pee, inject them, set them on the table, and then scan them from the bladder up. You don't want to inject them and then have them go to the bathroom because then by the time you get them on the camera, it could have been 15 minutes. It takes these old guys forever to pee. So have them go to the bathroom, then you inject them, set them up on the camera, get them started. And it's 4 to 5 minutes per bed position. All right, so administration with arms down. Then you have them move their arms up. You position them. You do the CT for attenuation correction. And then by the time you do the SPECT, you're at your uptake time. So super quick. Inject them on the camera. Scan them from the bladder up. And then, so injection or the acquisition time is about 20 to 30 minutes total. You do a couple minute bed position, 3 to 5 minute bed position, depending on the camera. If you have a digital camera, you can do it a lot quicker. You can do like 2-minute bed positions. So this is examples of the fluciclovine. Goes everywhere amino acid goes. That's why you see the brain. Those cells in the brain take up amino acids, especially, I forget how you pronounce it, but MET, methionine or something. Anyway, and choline, all those amino acids, brain just loves them. All right, so compare it to background. Small lesions, the uptake will be greater than blood pool. Larger lesions, the uptake will be greater than or equal to the bone marrow. One of the bad things with fluciclovine is that you have a wide variety of uptake areas, and there's a lot of things that are going to take up amino acids, so you can get more false positives. And fluciclovine was really great when it first came out. It had a great run. And then PSMA came out all flashy and flash in its Pluvicto. And then people started to forget about fluciclovine. But it is a really great drug. It shouldn't be that PSMA replaces fluciclovine. They both have their role. Just the problem with it is because you have this wider uptake area, you can get more false positives. normal biodistributions all over the place. Liver, pancreas, lungs, red bone marrow, myocardium, brain, skeletal muscle, goes everywhere. All right, image interpretations that occur. A negative scan, this is where the drug company made their mistake. A negative scan does not rule out the presence of recurrent prostate cancer, and a positive scan does not confirm the presence. So they shot themselves in the foot with that little caveat in the package insert. But the performance of Axumin seems to be affected by the PSA levels, and that's why what they say when the patient's PSA levels start to rise, that's when you should do the fluciclovine. When their PSA levels are high, the fluciclovine scan becomes more accurate. So you got to do it at the right time. So imaging with PSMA, there are 4 with another 5th one that's possibly coming. So there's Plarify, Posluma, Illuccix, and Locomets. 4 of them. Posluma just got FDA approved in 2024, around June or July, something like that. So piflufolastat is Plarify. I've used that one, absolutely love it. Not too familiar with Posluma, but it has different patient prep that makes it a little bit more difficult. You may want to research the protocol for that, but as far as your boards go, it's too new. It's not going to be on there. It's not on your exam outline yet, but you may need to know it because you may go to a place that's using it. You may work somewhere. So it's still something you need to know. In the long run, in the grand scheme of your life as a nuke med tech, I would suggest getting familiar with it. Maybe after you graduate, or if your clinical site is using it, look up the package insert and the protocol for it, compare it to what you know about the other PSMA agents. But I know the patient prep is a little bit different and the protocol is slightly different, but they're all different versions of PSMA. Now the gallium-68 ones, we have ghosteotide, which is Illuccix or Locomets. Different companies make the same exact drug, same compound that's bound to gallium. Remember, gallium has this really long positron range, so that affects us as well. F18 has a fairly short positron range, so you're going to get better spatial resolution with the F18 agent than what you will with gallium. And then some doctors will prefer one over the other because they know it has, better image quality or whatever. Sometimes it comes down to availability in the area. Sometimes it comes down to cost. Supply chain is still being worked out for a lot of these. Clarify was the first one to hit the market. It had 100% of the market share. And then they had availability issues and Pluvicto came on the market. And then you couldn't get, people would start their Pluvicto therapies and they couldn't finish it. And so patients were dying basically because they couldn't get their Plarify or their Pluvicto and they had already started the treatment protocols. It was a disaster. It was very poorly done, and it really turned a lot of doctors off of Plarify because of it. So some of them will prefer gallium because they think it's easier to make and get, and they're just frustrated with the company that makes Plarify. But other doctors will swear by it because Plarify does have better image quality. And then the therapy that's used for it, the theranostic therapy part, is the Pluvicto. All right, so indications for the PSMA routine clinical use. This is when you're monitoring somebody who has prostate cancer and you're just kind of watching them. Initial staging of prostate cancer. So when they first get diagnosed, they get PSMA and FDG and a bone scan. Do the whole gamut on them, see where the cancer is at, and then they determine how to proceed with their therapy. That's when the oncologist will determine their treatment plan. localization of recurrent or persistent prostate cancer, localization of prostate cancer, which is non-metastatic by conventional imaging, staging before prostate PSMA directed therapy. So this is done before therapy to make sure it's still PSMA avid tumors and to kind of plan the treatment. Potential clinical applications are like guidance of the therapy or guidance of biopsy, imaging metastatic prostate cancer, monitoring of systemic treatment. It also has potential uses outside of prostate cancer. There are some clinical trials looking at it for breast, for neuroendocrine tumors, for gliomas, for neuroblastomas, which is also neuroendocrine. There's a couple different things happening with PSMA where it has a few different potentials. Cervical cancer is another one. There's some female cancers. A lot of the female cancers will actually take up PSMA. Remember, it's not really prostate specific, so that was a stupid name. But so it is being clinical trialed for a lot of other cancers. So it has some other potential uses. With PSMA, patients can eat and drink normally, 20 milligrams IV, blah, blah, blah. This is a comparison of how they're done. Posluma is on here, and the manufacturer's on there as well. So the dosage is higher with FDG agents than it is with gallium. That's something to consider. The uptake time is also longer for gallium, and that's something that also needs to be considered. So overall, the radiation dose is going to be a little bit lower with the gallium agents. You need to wait a little longer to scan them. That slows down your day and affects your workflow. And then also, pictures are going to look not as great. And so you'll have less spatial resolution and whatnot. All right, so protocol for the PSMA lignans. Position them supine with their arms elevated above their head as tolerated. Make sure there's no metal and whatnot. CT scan is done first, vertex to mid-thigh, per institution parameters. I know some protocols that do from the bladder up on those, just like you do for fluocyclovine. That's the best thing to do because you don't want the bladder getting in the way. But it depends on the protocol, and some scanners are quick enough that it doesn't make that big of a difference anyway. Diagnostic CD can be acquired, and also the PET acquisition should start from the mid-thigh and extend to the vertex to exploit the reduced PSMA ligand uptake in the urinary system. 3D mode and 1 to 4 minutes per bed position, depending on radiopharmaceutical you're using and your camera manufacturer. Digital PET is going to be 1 minute per bed position. Other ones you're going to want to take for a little bit longer. Gallium you're going to want to take for a little bit longer per bed position because you gave the patient a lower dose. You're going to have a lower count rate. You're going to have plenty of counts with 3D mode anyway because it's going to be more sensitive, but you're also going to get more scatter. All right, so this is the PSMA ligand one. I put a toilet sign on there. You guys, I think, have seen this before. So inject the patient, let them uptake, give them a glass of water, have them go to the bathroom, and then you scan them in 3D mode. Normal biodistribution, it does have a kidney dominant excretion, so drink a lot of water and then go to the potty. Clear that activity out of the bladder. That's going to be healthier for them. Also, you really need them to void before they start. This is difficult sometimes with prostate cancer patients. Some of them can't empty their bladder in all the way. Some of them don't feel like they have to go, or they have trouble starting. They're urinating. Some of them have some incontinence issues. So that can cause contamination on there. It can cause the bladder not to empty all the way, which makes it harder to see if there's lesions really close to the prostate. So all those things can kind of get in the way, but the images are really good. These are some different PSMA agents that haven't made it to market. This PSMA 11 is the ghostitide that we have for the Illuccix and the Locomets. And then this one, DCFPLY, is the Plarify. I'm not sure what these other two ones are, but they're other ones that didn't really make it to market, at least not in the US yet. So with Pluvicto, look at how beautiful these images are. These are all different patients with different variations. A is pretty normal. G and F are not. They're very abnormal, as you can see, all this PSMA up in here. So patients are imaged with either gallium or the F18 PSMA agent, and then they're treated with lutetium. Pluvicto indication says adult patients with prostate-specific membrane antigen positive metastatic castrate-resistant prostate cancer. It's a mouthful. These are patients that have had their prostate removed. They've been castrated. And then the cancer has come back and has spread anywhere in their body. And those lesions are taking up PSMA. So very specific indication. Patients, it's not for patients that are first diagnosed with prostate cancer. This is patients who have had surgery, they've had chemo and or radiation, and their cancer has come back or has already spread to other areas by the time they found it. Stage 2 to 4 cancer, who have already had their prostate removed, and they've already had a PSMA study, so we know that these tumors are taking up PSMA. And they will have already been treated with androgen receptor pathway inhibition and chemotherapy. So what this is saying is they already got their treatment and it didn't work. So first thing they did, they got the prostate removed. Then they were treated with androgen receptors and chemotherapy, and it still is metastasized and it's still taking up PSMA. Now we're going to treat it with Pluvicto. All right, so same method, gravity method. And so short needle, long needle, right? The blue is the Pluvicto, the orange is the saline. So goes in, saline displaces it to the bottom, and the long needle sucks it out into the patient. Lutathera and PSMA are the same way. All right, this is the treatment protocol. Pluvicto infusion is done every 6 weeks for 6 cycles. These therapies are hard to keep track. Which ones are every 4 weeks for 4 cycles, 4 weeks for 6 cycles, 6 weeks for 6 cycles. Make flashcards, because that is something that you will be asked and expected to know, but it's very difficult to keep them all straight. Blood tests are done every 2 weeks. We want to, same thing as all the other therapies, we want to make sure that their platelet levels, hemoglobin, all of that is where it needs to be, and they're not like getting too, run down and too anemic or anything like that to continue. Side effects: fatigue, dry mouth, nausea, decreased appetite, changes in their bowel, or low blood counts. So this is before, after therapy. The first image there that looks really nasty, that's before the PSMA targeted therapy. Remember, it was normal to see like the kidneys, the bladder, the liver, and spleen. It was normal to see like parotid glands or whatever, but these are worse. Lacrimal glands, you see what looks like little eyeballs. But everything else that you see there, little bit of bowel, you see it in their bone maybe, all through their ribs, axillary areas, probably lymph nodes. You see it in their neck and their chest, probably also lymph nodes. It's really bad. But then the PSMA, they got their Pluvicto. After 1 cycle, it responded pretty well to the Pluvicto. You still see areas that are really avid with PSMA, but for the most part, it knocked them down. After just 2 cycles, that's a ton of improvement. And it's knocked down almost to normal uptake. You still see some like little areas. You see the areas that were really hot, like in the arm and their neck and their chest and their leg, are still taking up a little bit of PSMA, but it's if you look at the SUV values of that, it's a lot different. And look at their PSA values in their blood work. The PSA went from being over 100 to down to 0.6 with after just 2 cycles of therapy. So this one works really, really well when it works. Doesn't always work on everybody. Sometimes it's like too much heterogeneity or it's not taking up the PSMA anymore. And that's when it gets to the point that Pluvicto will no longer work either. And that's usually like no treatment options for them at that point.